Good afternoon. How's everybody? Can you hear me? All right, sorry. Welcome everybody to the 2023 DPT Research Symposium Evidence-Based Practice Celebration. Just a few housekeeping items before we begin. If you should need a restroom, feel free to get up at any time. They're right behind me and to the left, and there's a few refreshments over there if you should need some. So today, we bring you 7 group presentations that display the accumulation of the efforts put forth by the class of 2023 as they learned about the research process and about the responsibilities of an evidence-based practitioner. This is the last academic exercise that all of our students will complete, and I know they're very excited. And probably for many of you, it may be the last academic exercise that you'll complete, and just think about it, 18 or 19 years of education has gotten you to this point, so you should be very proud. Congratulations. For each group is allotted 20 minutes for their presentation. The presentations typically are about 12 to 15 minutes, with the remaining 5 to 8 minutes are reserved for questions. All audience members, family, friends, faculty, and student peers, please ask questions of the researchers and the students. They're very proud of their work. Each student in a group will participate in some way during the presentation. As a reminder to the presenters, when a question is asked from the audience, we do ask you to repeat it for all to be heard. This symposium is being live streamed for family and friends who might not be able to be in attendance with us today. We will try to keep on schedule. We will not move ahead in the timeline in the event family and friends are logging in just to hear a particular group, but we may run a little bit behind, but we'll try not to do that either. We will take a short break after the first 4 presentations, and then we'll resume. So as one group finishes, I ask that the next group get up and be prepared to do your presentation. Dr. Fitzgerald is helping with getting all of the presentations up so the students can come up, take their places, and we can move on from there. So as you can see, we do have a brochure with all the abstracts that the students put together, so hopefully you can access those. And any questions from the audience before we get started? No? Okay. So our first group is led by Elena Duffy and Maria Wells, who will introduce their group project to you.
Hello everyone, my name is Elena Duffy, and these are my colleagues, Maria Wells, Megan Tondra, and Alan Miller. Sorry, starting us on a bad note. Today we'll be presenting our findings regarding the research question, is the easy angle a reliable tool for assessing hip range of motion in elementary school-age children? Range of motion is an essential component of a physical therapy exam. It offers insight regarding impairments such as joint stiffness, spasticity, muscular shortening, and various others. Improved range of motion allows for increased participation in meaningful life activities, and thus is often a goal of physical therapy interventions. Hip mobility is especially important in the pediatric population due to various conditions that lead to decreased hip range of motion. These include Legg-Calvé-Perthes disease, slipped capital femoral epiphysis, developmental hip dysplasia, and others. Furthermore, 15% of pediatric orthopedic pathologies involve the hip. The hip plays an important role in balance, gait, and functional activities like squatting. It is also involved in articulations with the pelvis and the knee and may impact those joints. Assessment of hip range of motion can allow for early detection of pathology and appropriate management if indicated. In order for range of motion data to be meaningful in a clinical setting, clinicians must first have a tool to obtain such measurements. This tool should be reliable, valid, and relatively easy to use. Additionally, clinicians must also have established age and sex-matched norms obtained from a healthy population to which they can compare findings. Traditionally, the universal goniometer has been the preferred method for assessing range of motion due to its low cost and versatility. However, studies have found poor reliability with this tool in certain pediatric populations, such as individuals with cerebral palsy or femoral fractures. Other studies have demonstrated poor reliability for passive range of motion due to difficulties moving and stabilizing the limb while using both hands to operate the universal goniometer. The main limitations of universal goniometry described in the literature include the required use of 2 hands, the need for stabilization of the patient, and the lack of a standardized protocol for the pediatric population. Anecdotally, if you've been around elementary school-age children, you can imagine why these characteristics might make it difficult to use with this population. The development of new technology has led to the emergence of alternative tools for assessing range of motion. These include smartphone applications, digital photography, digital inclinometers, and digital goniometers, to name a few. While some studies suggest these tools are reliable and valid, there is limited research into any one device or tool, and very few studies have investigated the clinical applicability with a pediatric population. The Easy Angle, developed by Mellock, is a digital goniometer that may be used in place of universal goniometry. This tool requires only one hand to operate, can store up to 5 measurements at a time, and is relatively easy to use. These features suggest that it may be beneficial to use with a pediatric population. Current studies have demonstrated good intra- and inter-rater reliability for various joints. However, no published studies assess its use in pediatric populations, and no studies that assess the hip joint are available in English. Finally, regarding normative data, studies exist that focus on establishing normative reference values in adults. However, normative range of motion studies are scarce for the pediatric population, and those that exist consist of early studies using the universal goniometer. Normative data is essential in order to identify any deviations from typical development and to implement therapeutic interventions as needed. This study was conducted with 2 objectives in mind. The first is to establish normative reference values for hip joint range of motion using the Easy Angle in elementary school-age children in the context of age and gender. The second is to establish the intra- and inter-rater reliability of the Easy Angle device in measuring hip joint range of motion in the same population. Our research team conducted a descriptive study to obtain normative data and determine reliability, as discussed on the previous slide. This study underwent IRB approval, and parent consent was received prior to commencement of the study. Our study included 20 healthy participants, 9 males and 11 females from a local elementary school. The right and left lower extremities were analyzed separately for a total sample size of 40. Exclusion criteria included diagnosed musculoskeletal conditions, such as leg calve-Perthes disease, a bone fracture in the leg, or slipped capital femoral epiphysis, as well as diagnosed neuromuscular conditions, such as cerebral palsy, muscular dystrophy, or spina bifida. Prior to data collection, the research team conducted practice sessions with each other, as well as a practice session with a single participant whose data was not included in final analysis, to develop and refine the measurement protocol. 4 student physical therapists were split into 2 measurement teams. On each team, 1 researcher was designated as the rater, and raters remained consistent throughout the study. Raters were blinded by placing a piece of opaque tape over the measurement screen of the device, as seen on the right of your screen here. Each participant was passively measured for hip flexion, abduction, extension, internal rotation, and external rotation in this order. Hip adduction was not measured due to lack of reporting in the literature. For each motion, 4 trials were conducted, only recording the final 3. The first trial was used as a warm-up to familiarize the participant with the motion. After 3 measurements were recorded, the data recorder copied down measurements and cleared and reset the device for the rater. This first slide demonstrates the protocol for hip flexion range of motion measurements. As you can see in the video, we begin by assessing the hip in kind of a neutral or resting position and press the blue button on the device to indicate starting the measurement. We then passively move the participant's leg into hip flexion, bringing the leg kind of up towards the chest. And once we've achieved the maximum range of motion allowed by the patient, we press the blue button again to indicate that the measurement has been completed. This slide demonstrates the protocol for hip extension. And finally, this demonstrates the measurement protocol for hip internal rotation.
And I will summarize the results of our study, beginning with our demographics. We had a total of 18 males and 22 females. Overall, there were more subjects that were African American, and this group made up 75% of our total sample size. The mean age was 7.4 years old, and subjects ranged from 5 to 10 years old. This table lists the mean range of motion values by age. The 8-year-old category had the largest number of subjects, and the smallest number in the 10-year-old category. And then, as demonstrated in the green box, each range of motion value from all 6 trials was calculated, and the minimum and the maximum values were calculated for that specific measurement. All averages were fairly consistent between groups. This table allowed us to compare our average to similar studies which calculated normative data for the pediatric population. We calculated the inter-class coefficient for inter-rater reliability, which helped us to determine if both raters were consistent when measuring each of the 3 trials. By looking at similar reliability studies, we utilized the 3-1 model to calculate the ICC. Intra-rater reliability is considered good to excellent for both raters and for all 6 measurements. Values range from 0.807 to 0.971. Hip flexion was greatest for rater 1 and rater 2, which is in the green box, while the lowest ICC for rater 1 was abduction and extension for rater 2 in the red box. ICC values were also calculated for inter-rater reliability to determine if there was agreement between both raters. The values are also considered good to excellent, ranging from 0.778 to 0.911. Hip flexion was greatest, highlighted in green, and external rotation the lowest, highlighted in red. In comparison to intra-rater reliability, inter-rater reliability was slightly lower overall. An ANOVA analysis was completed to determine if there was a statistically significant difference between age and range of motion. As demonstrated by the p-value, there was no significance overall. Lastly, a t-test was completed for gender and hip range of motion. Overall, females had greater range of motion compared to males. Hip flexion and abduction were the only 2 values that were considered significant, which are highlighted in green. The results suggest that the Easy Angle device displays good to excellent inter- and intra-rater reliability when measuring each of the 5 hip range of motion values in the pediatric population. Inter-rater reliability was important to establish with this advice to ensure that results are reproducible and accurate between several therapists in the clinical setting. Intra-rater reliability ensures that the treating therapist of the patient could reproduce similar results from therapy session to therapy session in order to track progress of the patients. Each rater noted that the Easy Angle is very easy to use, especially since only one hand is needed to hold onto the device. This is something that would be very useful in the clinic, especially in the pediatric population when it might be more difficult to obtain measurements. As already mentioned, hip flexion had the highest ICC value. Raters note that it was a little more difficult to prevent compensatory strategies in some of the other subjects. or in some of the other movements, which may have impacted our results. Hip flexion was also the first measurement in our protocol, so subjects may have been more relaxed at this point compared to towards the end when external rotation was measured, and this had the lowest inter-rater reliability score. Overall, intra-rater reliability had higher ICC values when compared to inter-rater reliability. However, this is consistent with other studies that we reviewed during our literature search. Age did not have a significant impact on the average range of motion measurements, which is not consistent with other studies. Since the age range of our participants was small and included ages in middle childhood, this is most likely why there was not significant difference between groups. Overall, values were consistent with other studies, which is important to establish to ensure that our findings were not skewed from the norm. Females achieved greater range of motion across all 5 measurements in comparison to males, with hip abduction and flexion as being statistically significant. This finding is also consistent with previous research. There were several limitations to our study. Although we achieved a sample size of 40, which was adequate when conducting our preliminary power analysis, it was a relatively small sample size to establish a larger normative data sample. Our research group spent time prior to initiating our data collection to ensure that we were familiar with all the protocol and that both raters were consistently measuring each hip range of motion measurement. However, there were still differences that were observed, but this is not an atypical finding in PT practice. The protocol required approximately 30 minutes of each subject's time during the day, and given the age range of our subjects, some had a difficult time remaining still during the entire duration of the study, while others remained very relaxed during our data collection. So this could have resulted in a few outliers that may have impacted our results. Future research may include a replication of our methods with other pediatric populations in the United States. Our project was unique in the fact that it included mostly African Americans, which are often underrepresented in research. Additionally, increasing the sample size in the future would increase the amount of data to establish a larger normative data set. Finally, this device could be used in other conditions such as cerebral palsy or hip dysplasia. To conclude, the results of this study suggest that the easy angle is a reliable tool when assessing hip joint range of motion in elementary age school children for both intra and inter-rater reliability. This study also established a small normative data set using the easy angle for 5 measures of hip range of motion in children ages 5 through 10. And then we submitted our research findings to the Journal of Pediatric Physical Therapy, and then we also presented this at the OPTA East Central District Student Research Symposium this past fall. And then the last 2 slides include our references. And now we will open up the floor for questions. Thank you for listening.
I am curious about your recruitment strategies because, as you mentioned, 75% African American is not representative of our population.
So the question was about our recruitment strategies for this project.
So we worked with Dr. Doty to recruit a lot of our children from the local elementary school, the parochial elementary school in the area, and we were able to talk to them and kind of hand out flyers and forms and get information out to parents, and then parents kind of would give forms back to us in order to get their child to participate with us.
Great job on your presentation. I was wondering if you could provide some insight into the cost-benefit analysis of this tool, because you made it sound like it might be really of benefit, but sometimes it's hard to get new technology into a clinic for budget reasons compared to something that's pretty cheap, like a goniometer.
So that question was about the cost versus benefit of using the easy angle.
So currently the easy angle is retailing for about like $250 about. One of the biggest things are doing research like this to show that the easy angle is a reliable tool. in pediatric practice, we're always looking for different ways to measure range of motion and to get more accurate results. So I think a really interesting study would be to compare the easy angle versus a traditional goniometer to see how they compare to each other.
Very nice job. Would you change anything? Would you do anything different now that it's completed?
So that question was if we would change anything about our research project now that it's been completed. Okay, I can answer that one. I think overall the biggest thing we would change is just working on our recruitment strategy. So we found kind of near the end of our recruitment period, we were kind of desperate to get our sample size. So our research professor was standing out in the pickup line, asking parents, hey, did I turn that off? Okay, sorry. Hey, is your child interested in participating? So I think maybe going forward, going to the school in person prior to beginning our recruitment, and maybe us talking with the parents then, I think that would just make this whole project kind of easier to get our sample size without kind of getting down to our last couple of days and still realizing we needed people. But I think overall our design, I thought it was pretty efficient. I thought we achieved what we needed to achieve. So I think overall it was good. Thank you.
Okay, so coming to the stage, we are Emma Kondocker and Jordan Landkamp will introduce their group.
Hello, my name is Emma Kondocker, and this is Jordan Langkamp. Will be presenting on behalf of our group today, and then the rest of our group includes Corey Tomick, Sarah Overberg, and Kara Marshall. So the title of our project is What Makes a Clinical Instructor an Effective Educator? A presentation of the literature, and this was done by means of a continuing education unit. And our faculty mentor was Dr. Larson. Oh, okay. So I just wanted to give a little bit of a background before we get into the actual project itself. So as students in the Walsh DPT program, we do have 4 clinical experiences, and those are where we are out in the clinics and hospitals getting hands-on patient care with guidance from our clinical instructors. So all of us had interest in clinical education specifically, and all wanted to become a clinical instructor one day. So that's kind of how we chose this project. And as a licensed physical therapist, which will all be very soon, you are required to have a certain amount of continuing education units every couple years just to keep up on the literature and just continue your education as a lifelong learner. So we chose to use this as our platform, a CEU presentation, because we wanted to give back to the clinicians that give so much to us in our clinical education journey. So our purpose of our project was to discuss aspects of clinical education as it relates to the efficacy of a CI, and this is just when it relates to teaching students in the clinical setting. And we decided to put on the CEU presentation to invite local clinicians to our campus to help increase their confidence in future or current CIs, to provide resources for the stakeholders in clinical education, and to discuss the need for effective and passionate clinicians to help grow the profession. Our project is a little bit different from some of the other ones you'll hear today, as our outcomes, which Jordan will talk about a little bit later, are more focused on assisting students in presenting future CEUs and assessing the effectiveness of our presentation. So getting into our actual literature review and our whole process, clinical education makes up to 1/3 of the academic curriculum, which is a very large part of our education. And this is what, like I said before, we're getting hands-on patient care, we're developing our clinical reasoning skills, and we're learning from our mistakes with the guidance of our clinical instructors. So the CIs are a crucial player in PT education, as they are the ones that are developing us to be an entry-level clinician. So we all kind of had our own opinions on what made a great and effective CI, but we wanted to look further into the literature to see what makes best practice. So our clinical question for this project was, what makes an effective CI when teaching students in physical therapy? So all of us up here conducted all of the research using the various databases that are listed on the screen, and we also hand searched the American Physical Therapy Association website. We filtered our articles based on the titles and the abstracts of the articles, and we split those into the main criteria for our literature review and our CEU presentation. And a total of 32 references were used for the event. This is our search strategy that we just put right into the database. We just wanted to throw it up here in case you were curious to look at that. And then these next two slides are going into our actual sections of our presentation. So the first one is from clinician to clinical educator. This section discussed the various requirements that it takes to become a CI, an optional course that you can take, some barriers to being an effective CI, and the road to competence. The next section was how to begin the process, and this just described the different pathways that you can take to become a CI, as there are many. And then the third section discussed the responsibilities of the CI, which could be a mentor role versus needing to assess the students as well. And we also discussed how to address poor performing students in the clinic and how to create an optimal learning environment. And then the last three sections included student perspectives and characteristics of an effective CI. So this section just went beyond the basic responsibilities and included student perspectives that we found in the literature. The next section was effective communication, and this could be between the student or the university program. This also discussed different ways to give feedback and to discuss progress, how the student is progressing throughout the clinical experience. And the last section is laws and ethics, as this relates to students in the clinical settings with their CIs, and also barriers to reporting any issues that may exist. This is our timeline of events. So our project began about a year before the event took place, and this started, oh, my bad. Okay. This is the timeline. So this began about a year before the event, and that began with creating our clinical question, figuring out what our demographic would be for our attendees, and then we dove into the literature from there. And our presentation actually began to take shape around 4 months before the event. But throughout this whole time, we had been communicating with the Barrett Business Center, which is where we're at today. This is where we did our presentation in November. And 2 months before the event, we submitted our CEU application to the Ohio Physical Therapy Association, and they approved us for 2.5 CEUs for free for our attendees. And the save the dates were sent out around the same time as we sent out our application, which I have a picture on the next slide of. Our invitations were sent out a month before the event, and both the invitations and the save the dates were sent through email, and registration was done through Eventbrite. Refreshments were ordered by Ms. Crum prior to the event, and an email reminder was sent to all of our attendees just to remind them of the event and to send them the presentation as well. And then the actual day of the presentation was November 19th. Here is this, sorry. Here's the save the date. And then the day of the event. This took place from 9 to 12 on November 19th in the Barrett Center. And our presentation included information from the literature review, which I already covered, and also information on matching students to their clinical placements from the Director of Clinical Education, which is our faculty mentor, Dr. Larson, and we also included our student experiences from our clinical education. At the end of the event, we had a Q&A session and a course survey. So 37 of our 40 attendees completed the post-course survey via QR code or a paper copy that we provided, and certificates for attending the event were sent out 11 days after the event via Microsoft Mail Merge, and a list of our references were sent with that as well. And I will hand it over to Jordan to discuss our outcomes.
So Emma had previously mentioned that our study is a little bit different compared to some of the other ones in the room today. So I'm going to go over the results that we got in our post-course survey from the attendees that attended the lecture that we presented. So as you can see, we had participants provide a bunch of information to us to give us a better understanding of who we were talking to in the room. This included the position they held, what company they've worked at, how long they've been a CI, and how long they've worked at the company they've been with. The three main attendees that we had were either new CIs, so new clinicians that haven't taken a student yet that are interested, CIs that have been working for up to 40 years in the field, and then SCCEs. And SCCE plays an important role because they connect the clinic with our academic program, and they kind of are the ones that lead us into the clinic and get us settled. And so they're also kind of the mentor for the CI in the clinic. The event capacity was held for 100 attendees. We had 50 who registered, and day of we had 40 people who attended, with some letting us know that they were unable to make it. The reasons for attending were to improve student experiences that they've had in the clinic, to seek to improve their own skills as being a CI. Free CEUs, as we mentioned, we have to have those as we continue our education. And then ethical and legal implications, as that's not always something that we refresh ourselves voluntarily without this. And then just the updated research and interest in this topic. Like I said, we had clinicians that had been new, only in the field for less than a year, and people who had been in the field for almost over 40 years. So to go over the results, the first one we asked was, on a scale of 1 to 5, did the course provide you with information, strategies, and techniques for enhancing your effectiveness as a CI? We had 37 who reported this, and you can see about 23 participants, or 62%, gave us a 5, 8 gave us a 4, and 6 gave us a 3. There was no one that rated us at a 1 or 2 for this. And at the bottom, you can see that 1 was, this course didn't provide me with any more information, and 5 was, this course provided me with a great wealth of more knowledge. The next one was, after this, do you feel more prepared to practice as a CI? The most important thing about this is that there were only 3 people in the audience that have not taken a student yet, so they were the only 3 that answered this question. 2 of the 3 answered that yes, they were more prepared to take a student after attending our lecture, and 1 said no. The next one was, on a scale of 1 to 5, how would you rate this course? So 1 being, they would not recommend this course to other colleagues, and 5 being that they would recommend it to other colleagues. You can see that we had 37 people that responded to this. 25 gave us a 5, so 68%. 10 gave us a 4, and 2 gave us a 3. Again, no one rating us at a 1 or a 2. And then the last question we asked was, if you are an SCCE on a scale of 1 to 5, how much do you believe this course offered more information to help develop an effective CI? So again, we only had 9 SCCEs who attended, and so they were the ones that answered this. You can see that 11 of them gave us an 85 and 2. There was a little bit of difference in numbers for how they reported they answered this, so I have a feeling that a few people who attended may not have read the question and accidentally answered it. But on our initial reporting, we only had 9 people who were an SCCE. So the results, we had a little text box where they were able to just give us some overall feedback on how they felt we did, and some information that they gave us. And the overall opinions about this course is that they appreciated the student experiences. They really liked to hear the first-person experience from all of us and what we thought made an effective CI, and what may not have made an effective CI, or what could be done better in the clinic. There were a variety of topics. They thought it was well organized, and overall, they just thought that a more interactive versus a lecture style would be more helpful when diving into this information. The next thing we asked, which is more for continuing on for other students and preparing a CEU, is what did physical therapists want to hear about? What were they interested in? Where did they feel like they lacked knowledge? And so they listed quite a few things, but one of the main things that kind of correlated to what we presented was that they wanted more information on a difficult student, or a student that may not be progressing, and how do you take that student under your wing? How do you help them, and how do you get them to the entry level that we are all nearing right now? That was that. So for the discussion, after we went through all of the information and we went through our research, we found that there's not one distinct way to determine how you are as a CI and to determine your competency. Really lifelong learning and being able to continue to dive into the research, be able to have conversations, be able to attend future events is really what helps you grow and develop your skills. The audience, again, enjoyed the personal experiences. First-hand experiences are the best because you get to have actual conversations about how things went. I know we can all look at research and say, you know, in the black and white, this is how it happens, but in real life, it's not always the same. The education on the ethical and legal components was also very popular. As I said, most people don't voluntarily go look into that information, but it's nice when it's presented to you and it's kind of right there for you. And again, we had the question in A at the end where we were able to dive more into our personal experiences, and there was one assessment tool that we gave them that they really liked that they were able to take back to their clinic and able to kind of start evaluating their future students with that as well. So conclusion. We determined that early and constant communication between all of us and our team members is important for this extensive literature review, as well as organizing all of our thoughts. At the beginning, we kind of had all these resources that covered many different topics, but once we started breaking it down into the topics that Emma discussed, we were able to start taking those research articles, breaking them into different sections, and really building this foundation of a lecture to present to the clinicians that came and give back to the people who do so much for us in the clinic as well. Deadlines must be set and abided by in a timely manner. We had a lot of moving parts where we were doing our part, and we were also working with the Barrett Business Center to make sure that the event space was held and that we were able to be in here for our event. Again, talking about the themes and separating articles was really important, and then finalizing everything too, as well as just presenting this to different faculty before to get feedback to make sure that the presentation was the best it could be and that there weren't any changes we had to make. And then we also had quite a few people, and I feel like COVID's changed the day, or the way of the days now, where a lot of people want an online option. And they did ask if there was any way to attend online, and unfortunately we did not have that. But we do recommend making that an option in the future, just so that more clinicians would have access to it and we can reach an even larger audience. And overall, we received great feedback from all the attendees. So how does this impact our profession? Like we have all mentioned, we're all soon going to be new physical therapists, but without the help of those CIs getting us to that point in the clinic and really building our skills, along with our faculty building our skills in the classroom, we wouldn't be where we are today. So this information helps those physical therapists with this to build their information, their knowledge, and how to be that effective CI and take the students. And we also hope that the outcomes of this will help future students who may want to put on a presentation on what to do and how to do it, and give them a little bit more of a leeway in what to do. And so the way that we researched, or we shared our research, was that we had the CEU event here in the Barrett Business Center in November, and we had to put that application in through the OPTA for them to review all of our information and then approve us for the 2.5 CEUs. Here is all of our references listed that we use throughout our presentation. And any questions?
Yeah, I had a question on if you felt the timeline was an appropriate amount that you guys used, because you said at 1 year is when you kind of just started, but then at 4 months it started really coming together. Did you wish you had more time or less time, and how would you change it?
So the question was on the timeline we had, whether we felt like we had enough time or if we would have changed how we conducted our studies.
I think overall we had enough time, but if I were to do it again, I think we would stick more to our deadlines. I don't think we realized how many people needed to read our literature review, get those revisions back, and do them again. That for the paper itself, for the save the date flyer, even for the invitation we sent out, we had to get a lot of revisions. So in all, we had a good timeline, but just sticking really hard to the deadlines is important.
What were major themes that you found in your literature search for what does make an effective CI?
So the question was, through our literature review, what themes do we find that really made an effective and competent CI?
So we each found a topic that we personally found interesting. My specific one was effective communication, and I thought the literature really broke that down very well. It's something that I utilized a lot in my last clinical, and I just really appreciate the communication that CIs have to have with each and every student. We also talked about good qualities that make a CI. We talked about laws and ethics, and those are two topics that I hadn't really considered before. So to learn more about that definitely gave me a deeper appreciation for my CIs.
We're keeping the mic on this side. Is there talk of future Walsh classes continuing this CEU, whether it's research or just in the curriculum as itself?
So the question is whether or not throughout the curriculum, if there's going to be future CEUs from other DPT classes that follow us.
So I have heard that there are future CEUs that are going to happen with the classes that are under us. I don't know the topics yet, but each of our faculty members, our advisors, they pick the topics. They'll, give us a list of 4 items to choose from, and then as a group we kind of collaborate and figure out exactly what we want to do. So I definitely see this happening again in the future, which is a big reason why we put this presentation on, was so that the classes under us had something to kind of go off of, because this was actually a groundbreaking CEU event for Walsh DPT students. No one else has ever done this before.
So it sounds like you had a pretty good turnout locally. Have you considered doing the same presentation for a national conference or to a larger audience?
So the question is we had a good turnout with our local community, but have we ever considered doing this at a national level?
Sure. No. Since this is the first one, I think this is a good first step.
I will say, however, though, there is lots of talks within our field about how to make a competent CI, and I do think that this conversation will continue to grow, whether it's in our program or at a national level.
So I guess I might be the last question with our time, but given this experience and then your experience through your 4 clinical education experiences, how many of you want to be a CI and why?
So the question was, given all of the research that we did and experiencing our last clinical just a few months ago, how many of us want to be a CI and why? I think all of us, I'll speak for us. I know personally I want to, and I think it's to give back to students like we were given the opportunity. I was lucky enough to have 4 amazing clinicals with 4 amazing CIs who I can still reach out to this day. And without them, I probably wouldn't have the confidence that I have now to continue on to being an entry-level clinician.
All right, our third group is led by our speakers today, Lauren Ricosi and Joshua Neer, and they will introduce their presentation to you on the project.
Hello, everyone. Our group will be presenting on Walsh University's annual checkup by a physical therapist and its outcomes from a quality improvement project. The presenters will be myself, Lauren Ricosi, and Josh Neer, and our other group members joining us are Rachel Thorne, Rosie Freeby, and Caleb Freeman. The faculty mentors we would like to thank for their guidance and support throughout the completion of this project are Dr. Christine McCallum and Dr. Lee Murray. The purpose of our research project was to complete a quality improvement assessment of Walsh University's annual community clinic, which we did so through a retrospective descriptive study. In the following slides, we'll give some more detail regarding the background of Walsh's clinic and then transition into the outcomes of our project. First, I would like to highlight our project goals, which were threefold. The first being to collect baseline data from the clients served in this clinic since 2016. Secondly, to substantiate the benefits of implementing a PT-led annual checkup and how it relates to the APTA's stance on the subject. And lastly, to make recommendations to enhance the delivery and documentation of the clinic moving forward in the coming years. Next, I would like to give you all some background on the clinic. The Walsh DPT program implemented an annual community clinic into its curriculum in 2010. This clinic is student-led and created by DPT-3 students who provide mentorship to the first-year DPT students who take the lead on conducting a client evaluation. Both DPT-3 and 1 students are mentored and overseen by VA residents and other DPT faculty. This is an annual event held on Walsh's campus each spring. The average age range of clients that are served is typically between 40 and 75 years old. However, we do offer to serve any clients 18 years and older. Since 2016, our clinic has served over 500 clients, and we typically average anywhere between 80 and 100 clients served each year. I would just like to note now that this project was completed before this year's clinic held just a few weeks ago on campus, so the data that you'll see is representative of the 2022 clinic and the years before. Towards the end of our presentation, Josh will discuss some of the outcomes that we did note from this year based on the recommendations that we made and were able to implement in this past year's clinic. Our mission is to provide a learning opportunity for Walsh DPT students. This includes hands-on experience for the first-year students and a mentorship as well as leadership opportunities for the third-year students. Our clinic provides a cost-free physical therapy health and wellness exam aimed towards quality of life improvement and injury prevention for clients in the local North Canton community. Our vision for the future is to expand the incorporation of healthcare services available to our clients in the community and to establish a consistent client base to track and measure their progress annually. This slide provides a visual hierarchy of our clinic. Overseeing everyone is our DPT faculty, who directly oversee 2 project managers, which were DPT-3 students. This includes clinical services and operations management. Each of these 2 project leaders oversee 4 other team leads below them, totaling 8 others, which are also led by other DPT-3 students. And you can see the 8 listed on the right side of the screen. As mentioned earlier, part of our mission is to expand the community's understanding of a physical therapist's role and significance in health and wellness. The APTA released a position statement in 2019 stating that they recommend all individuals visit a PT at least annually to optimize movement, promote health and wellness, and slow progression of impairments, activity limitations, and participation restrictions. The focus of our clinic is to offer a service that is consistent with the profession's goals. The APTA has also identified several benefits of a PT-led annual checkup. Client health can be tracked over time and analyzed for signs of progression or regression, and then if problems are identified, a referral to either a PT or another healthcare provider can be given. Additionally, this creates an ongoing relationship between the PT and clients in the community, which can help build rapport. Currently, much of physical therapy practice is within the realm of tertiary prevention, which are actions taken to limit disability and improve length and quality of life among individuals who are already managing a disease or disability. This concept falls into one of our roles of managing disease and disability. However, as a profession, we have the capability, knowledge, and skill to provide primary and secondary preventative care, which focuses on preventing a disease before it develops or detecting a disease early on and intervening. This is where our role as physical therapists can expand into prevention, health promotion through education, advocacy, and collaborative consultation to connect clients with appropriate healthcare providers as needed. Now we'll switch gears to focus back on our evidence-based research project. We looked back at the data collected from our clinic, analyzed the outcomes, and assessed how we can improve the clinic moving forward. I'll hand it over to Josh to discuss the methodology and outcomes.
Thank you, Lauren. So diving into the methodology, there we go. Diving into the methodology of our descriptive study, our group wanted to investigate returning clients since 2016 who had attended the community clinic at least twice, and one of those times including the 2022 community clinic. There were over 500 clients served since 2016 who volunteered to participate in our community clinic, and of those, only 28 were found by investigators on file or on Walsh's EMR system that met this criteria. Data then was collected through past intake forms and evaluation sheets filled out during previous community clinics. This left our investigators 12 clients with comprehensive files that could be utilized for a more focused review on specific outcomes we wanted to further evaluate. This slide shows a comprehensive list of all of the outcomes we collected and analyzed from these 12 clients. This included demographics, health and safety questions, physical performance measures, and whether or not a referral was made to another healthcare professional. Diving into the demographics, of the 12 clients reviewed, 5 were male. There we go. 5 were male and 7 were female, ranging from ages 29 to 80, with an average age of 68 years old. As for the work status, most clients were retired, with only 1 client working part-time, 1 full-time, and 1 on disability. Many clients were college educated as well, with 5 clients having a bachelor's degree and 5 having higher education. Some takeaways we had from our intake forms included that 75% of these clients reported visiting our community clinic for an annual health and wellness screen, while others reported doing so for balance deficits or pain. Between the 12 clients, there were a total of 23 returns, making an average return rate of 3 per client. We also analyzed if clients had experienced any falls in the past 6 months or not. No clients in the 2022 community clinic reported having a fall and did not report having a fall in subsequent years, except for 1 client who was the same client reporting using an assisted device for functional mobility. The physical performance measures utilized for our clinic for the past several years include the 10-meter walk test, the timed up and go, the alternate step test, the BEST test, the 5-time sit to stand, and the 4-stage balance test. These measures were used to help measure clients' predictive decline in function, their increased risk for falls, and the assessment if they're safely able to ambulate within the community. Although these measures had been standardized for every client to perform in previous community clinics, there had been inconsistencies with either improperly recording results or lack of reporting the results of measures. So in general, though, we saw a decrease in clients' gait speed that showed an increase in their potential risk for fall from 2016 to 2022. So now, there we go. So we've continued to utilize these measures due to a 2018 systematic review by Kavanaugh that found sit-to-stand trials, standing balance, and gait speed all could be utilized in identifying preclinical disability regarding functional mobility, activities of daily living, occurrence of falls, and even hospitalizations. This review shows that the value these performance measures utilized at our community clinic in evaluating our clients for present or future risk of disability, and the role a PT can have in a clinical practice to help predict disability and make proper recommendations and referrals when needed. Another important component of our community clinic that we take pride in is being able to appropriately refer clients out to other healthcare providers. We found that 5 out of 12 clients were referred out 1 or more times since 2016 to different types of physical therapy and other professionals as well. No consistent trends could be found with referrals made to clients who showed predictive decline in function, but we did want to highlight 1 client that may have benefited from this process. So here's a case study that we have presented that this client has come to our community clinic a total of 5 times, reporting an annual health screen as her reason for visiting each year. This client reported having multiple falls in 2018 as well as 2019 and was able to be referred out each year for vestibular therapy and then outpatient and women's health physical therapy. Since then, she has not reported any more falls, but has shown consistent decline in her performance in both her 10-meter walk test and her 5 times sit to stand, putting her into a fall risk range for her respected age group. Although no conclusion can be made on whether these referrals had any part in this client having no further falls in 2019, it is important to note that our students were able to make proper referrals out for this client, and that this client is a great example of someone we want to continue to invite back each year in order to continue to track her progress and provide appropriate support and care to promote overall better health and wellness, and to others similar like her. There are many strengths and areas of improvement our group found through this quality improvement assessment of Walsh's community clinic. The strengths found included improvement over time with the design and thoroughness of our intake forms, updating our sleep, mental health, and socioeconomic status screenings to help capture a better picture of each client and their potential needs, as well as high satisfaction and perceived student benefit from both first and third year DPT students from Walsh, and lastly, seeing an overall increase in our community and surrounding communities' involvement in our clinics since its creation. As for areas of improvement, one focus of concern would be the inconsistencies with the delivery of clinical services. This would include the lack of consistency with documentation and completion of required aspects of the health screen, including the performance measures and referrals, and if they were reported properly. We also saw a lack of preparedness to assess and track returning clients' performances compared to their previous years at the community clinic. In order to improve these areas of focus, we came up with some strategies to implement into this year's community clinic held a few weeks prior this month. The main focus is being standardization within these 4 components of the clinic. We looked to standardize our evaluation sheets and intake forms to ensure data was collected in an orderly fashion. Also provide first years with a checklist on what the expectation was for documentation to ensure fewer recording errors. Require completion of chosen physical performance measures in order to better track patients' performance over time. Prioritize the education to third and first year students regarding the purpose of our clinic and that every client that would come in would receive a health and wellness screen. And lastly, developing holiday cards to send out to previous clients who had attended the community clinics in the past in order to encourage returners. With a great collective effort from our class, faculty and staff, and the class of 2025, we were able to achieve many of these strategies just discussed this year. We were able to perform all 4 performance measures with each client, except a few who are not applicable. We were able to improve upon our documentation of client information properly into Walsh's system for future tracking and research purposes. We were also able to create a new reference packet and video for first and third year students, emphasizing components of the health and wellness screen. And lastly, we were able to engage with previous clients from the past year, sending holiday cards to encourage them to return to this year's clinic. Overall, we had 101 total clients come to this year's community clinic, with 33 of those being returners, marking 3 more than the previous year. While we were able to make these improvements to this year's community clinic, it is our hope for future classes to continue to build upon these changes made this year and improve our annual community clinic's operations so we may continue to have a positive impact in clients' lives and our community's overall health and wellness. This presentation was presented at East Central District Student Symposium in this past November, which went under a peer review portion. And we also would like to just give a special thank you to the staff and faculty here at Walsh for their time and efforts in helping us with our project. And here's our references. Any questions?
Great work, guys. My question would be, based on your experiences with the clinic and the research and everything, and as you mature into the physical therapy profession, do you think you'll incorporate, if possible, some of these screenings and wellness exams in your career, again, depending where you're at?
So your question was just to see how, if we would move on with these outcome measures to the future.
I definitely found myself in my fourth clinical already applying these outcome measures, so I definitely see myself continuing to do that as I get into practice. They've been very beneficial to be able to track a patient and client's progression throughout their plan of care.
I'm just curious, is there any follow-up with these patients that come through and be evaluated? Is there any follow-up to see if they have followed through with the recommendations that you make?
Yeah, so the question was is if we have any follow-up for them following our clinic. Yeah, I'll take this one. So we have, everyone who returns, like we do have some follow-up. So like one of the clients who came in, like I actually got to work with again this year. And so I was able to see how they've improved or regressed over the years because we've been collecting the data. I know in the future, we haven't like followed to see like all the recommendations we give. We don't know specifically if they've gone to them. I know it's in the works for the future to try and find a way to do it. It's kind of hard to, because of like some HIPAA violation, and then try not to, because we're going to be done. And so like we don't know if they're going to be referred and get there in a month. They could be get there yesterday. We don't exactly know. So we're still trying to figure out the best way to go about that, but that is something that we'd like to do in the future.
I'm just curious, is there any plan for like a returning client to give the student that's going to be seeing that client their past information on like how they've performed in past clinics, just so that they're able to give like more real-time feedback to the client when they come each year?
So if I understood correctly, you said that you want to know how we are going to be able to relay information more appropriately and quicker to the new client coming in, or the returner, I mean.
Yeah, like will the student receive information on their intake form of like their past scores?
Yeah, so like if it was
numbers?
in the intake prior, gotcha.
So that's the goal with our electronic medical record, is to be able to track our patients a lot better, or our clients a lot better. So ideally, in the future, when you have more information, future students will be able to look at that client's history and see what they were there for in the past, as well as what maybe they need to look at for that current visit. So yes, it's in the works. We just don't know when that's going to happen.
Hello, thank you so much for your project and your presentation. I think you guys did a really great job. My question is kind of twofold because you participated in a quality improvement project. So what's your view on quality improvement after going through a project like this, and what advice would you give to classmates or clinicians who are looking to do a quality improvement project in the future?
So the question is what do we feel about how the quality improvement went, and then what advice we would give in the future? Yeah, so I thought it was useful because a lot of us ended up being leaders for the community clinic this year because we had a deeper insight for this project. And so because we were able to go back and see what things needed to be improved on and what things worked well, we all kind of stepped up and tried to take a leadership role to standardize. That was a big thing for our project, to standardize the process. And so I guess advice for the future would just be, once you go in and just kind of see what needs improved, just trying to break it down and make it as simple as it can, and then what we can delegate to everybody. So that's what I think. Anyone else?
So I will invite Lauren Skillman and Cade Lloyd and their group to introduce their project.
Hi everyone, my name is Lauren Skillman. These are my classmates Cade Lloyd, David Taylor, Nathan Langenfeld, and we have Connor Haluk on the phone over here. He couldn't be here today, but he's still participating. Cade and I are going to be presenting our research, which was titled Single Leg Vertical Jump Test Reference Data for College-Age Female Athletes, a Pilot Study. We would like to thank our faculty mentor, Dr. DeLeandro, for helping us. So to get started, I want to give you guys a little bit of background information on the incidence of ACL injury rates among females. That way you can better understand why having an outcome measure such as the single leg vertical jump test is so important to help us potentially lower the incidence. So if you follow women's sports at all, you probably know someone or you've seen someone who has had an ACL injury at some point in their life, whether it be high school, college, or professional. One of the studies that we looked at found that 1 in 21 female athletes compared to 1 in 50 male athletes ruptured their ACL in a window that spanned between 1 season and 25 years. So one way to potentially lower this risk is to determine who is at risk and promote appropriate interventions to lower the risk. So how can we determine who is at risk? There are certain movement screen assessments that may be successful at identifying risk for ACL injury based on limb asymmetries using the Limb Symmetry Index. The Limb Symmetry Index is a ratio of performance between limbs that is often used to assess strength, function, and mobility. A value of greater than or equal to 90% is considered satisfactory for return to sport as an indicator of decreased risk for injury. The single leg vertical jump test is one movement screen assessment that can be used to determine limb symmetry index. It is a simple and quick measure that provides a direct measurement of vertical power and movement quality of the lower extremity using a Vertec type device. So not only can we look at the height that the athletes jump with this test, we can also look at their quality of movement when they perform the jump, like if their knee is caving in with a valgus collapse or if their foot is pronating when jumping, which would be an indicator of an increased risk of injury. However, despite the single leg vertical jump test being accessible for assessing limb asymmetries, there is very little research regarding this test, which is why we decided to conduct this research. So in our articles, we found that the most common return to sport battery to assess limb symmetry index is actually the single leg hop test for distance. A total of 55 studies used the single leg hop test for assessing limb asymmetry. However, only 6 used the single leg vertical jump test. And this is interesting because these same studies actually found that these tests look at 2 different things with the lower extremity. The single leg hop test looks more at coordination and proprioception and balance, and the single leg vertical jump test only really uses coordination. Athletes who perform well with the single leg hop test do not always perform well with the single leg vertical jump test. And it has also been found that with the single leg vertical jump test, the knee only contributes 13% of the work, but with the single leg hop test, the knee contributes about half of the work. Very few studies that we found focus on female athletes alone and report one singular mean, not split based on gender. And most of the studies focus on ACL athletes post-ACL reconstruction and not on healthy individuals. And we wanted to have the normative data available for these athletes to see how they compare with healthy individuals. So our objective was to gather normative single leg vertical jump height reference data for healthy female athletes age 18 to 24 using a Vertec type device. The device we used wasn't the Vertec brand, but it was pretty much exactly like a Vertec, it just had a different name. And we also wanted to assess intra-rater and inter-rater reliability of the single leg vertical jump test using a Vertec type device. So once we received IRB approval, 2 of our primary investigators reached out to a coach or a coaching assistant here at Walsh, either face-to-face or through email. And then once we received permission from them to start recruiting, the coaches made an announcement for the athletes for the specifics of the study, and which took place here at Walsh University and the Cecchini Center. Average demographic statistics were calculated for age, height, BMI, and standing reach. We looked at average jump height and limb symmetry index, and then categorized that based upon age and sport for both the dominant and non-dominant legs. And we assessed inter-rater and intra-rater reliability using an ICC coefficient. So our inclusion criteria for our subjects, they had to be a female athlete at Walsh University aged 18 to 24. Our exclusion criteria, they couldn't have a recent lower extremity injury that required missed time in sport, medical care, or surgery on either leg within the past 6 months. Our goal for the number of subjects that we wanted was 60. However, we found the recruiting process was kind of difficult, and we were only able to gather 29 athletes here. We had 16 from soccer, 7 from track and field, 5 from tennis, and 1 from basketball. So on testing day, our subjects first signed an IRB approved informed consent. And once they were in the testing area, we had them undergo a dynamic warm-up, which you can see up on the screen here. We just wanted to give them a good warm-up to lower the chance that an injury could occur while performing the jumps. So we had them do 1 practice jump on each leg, and that was followed by 3 score jumps on each leg, and we took the average of 3 trials for the right and left leg. We gave them clear instructions on how to perform the jumps and utilize the Vertec type device. So what we had them do was stand flat-footed under the Vertec, and then we instructed them to perform a single leg squat as deep as they could go and explode up and jump up as high as they could, while timing the jump to hit the veins on the Vertec at the highest point to make sure that we got the most accurate measurement. They weren't allowed to do a running start or anything, but what they were allowed to do, perform arm movements to build up momentum. And then for recording jump height, we first recorded their initial standing reach height by having them reach up as high as possible to a tape measure that was flat on the floor. And then we took their maximum jump height that they got on the Vertex, we subtracted that from the standing reach height, and that gave us their jump height.
All right, so let's talk about statistics a little bit. So as Lauren stated, we kind of focused in on reliability as well as limb symmetry index. Since this was a study to look at normative values, we focused limb symmetry index on dominant versus non-dominant legs, whereas previous studies for those who underwent an ACL reconstruction looked at operative leg versus non-operative leg. So this is our difference as far as normative study goes. And that's calculated by taking the involved or injured limb divided by the non-involved limb, or the dominant over the non-dominant. So that's how we calculated limb symmetry index. We also focus on reliability because that is important clinically. For example, if one therapist does a test one day, it has to be consistent and reliable for another therapist maybe another day, as well as the same therapist on different days as well. So that's why we focused on reliability. So here are our average jump height according to age. As you can see, we have it broken down from dominant leg to non-dominant leg. Overall, the average was 32.26 centimeters for the dominant leg and 33.03 centimeters for the non-dominant leg. As you can see, the 21-year-old age group scored the lowest, with the 19-year-old age group scoring the highest on average. Here is the overall mean scores according to the rater with right versus left legs. There was only a 0.01 centimeter difference in the average between the two raters between trial 1 and 2, right and left. So there's some pretty good consistency going on here with our statistics, which is something we wanted to see. So here is our average between trial score, as you can see for investigator 1 and investigator 2, all 3 trials, right and left leg. So there is a maximum difference of 0.14 centimeters with trial 2 and 3 on the right leg. So that is the maximum discrepancy that we saw with our average between trial score. So once again, we're seeing pretty good consistency here, pretty good reliability. So we're expecting to see good things when we did our data analysis. This is the limb symmetry index by age, and as Lauren stated previously, we were looking for numbers above 90% to indicate a good limb symmetry index, and as you can see, we achieved all of that, above 90% for all of the age groups here. So we reached the desired 90% plus. The highest mean score was for 18-year-olds with 100.59%, and the lowest mean score was 98.31% for 21 years. Here is the intra-rater reliability, and this can be classified as reliability within a single rater. And once again, for reliability measures, we are looking for a number above 0.9 to indicate excellent reliability, and we achieved that for all of the values here, as you can see. So we found that it had excellent intra-rater reliability across the board for raters 1 and 2, right and left legs. So this was a good number for us. Next, we have inter-rater reliability, and that is the reliability between 2 clinicians. And once again, we're hoping to achieve above a 90% value, and as you can see, we achieved 99% value here. So once again, achieving excellent inter-rater reliability. So that is a good number as well. So in general, the findings of our study support that the single leg vertical jump test is a reliable and easy to use test that requires little equipment. Therefore, the results of the study support that it is a versatile measure in young adults. With the high reliability measurements that we calculated, it is also consistent within and between the raters. That is what we found. So the results of this test allow for more future research to be conducted. So we tried to find that gap in the literature and kind of fill in those normative values, since there was not much previous literature out there in regards to normative data. Also, we wanted to focus on the reliability and find those numbers as well for normative data, because there's been previous literature on athletes post-reconstruction, not so much on those of healthy individuals. So we wanted to focus that on reliability in regards to the tests and measures of this. Some limitations of our study include we didn't get as many participants as we wanted. I think we finalized with 29 people, and we were hoping for a higher number than that. Also, previous studies showed that the Vertec type device was shown to not be valid in previous studies. However, we did not focus on validity for our study. Furthermore, majority of our participants came from a very few select sports here, and we were hoping to get kind of a more diverse group as far as sports goes. However, once again, this study can lead to future studies, and hopefully that they can fill in those gaps or do those things that limited our studies potentially. In conclusion, a single leg vertical jump test appears to be a quick, easy to use, and reliable source of measurement. The study did attempt to bridge the gap of literature, but more studies should be conducted in the future, and also look at using the Vertec type device versus using a force plate or another source of measurement as well. This is our plan for dissemination. So we did submit and publish a manuscript to the International Journal of Strength and Conditioning on January 16th of this year. As of March 13th, our current status requires revisions in order to be published. So that is our current standpoint for that. Here is our reference list for this project. And then, does anybody have any questions?
Did the athletes wear the shoe wear of their respective sports, or were they just requested to wear tennis shoes, or how did you guys go about that?
So the question was, were the athletes required to wear a specific shoe, or were they just wearing any type of shoe? Is that what you were asking?
I can take this one.
Gotcha. Okay. Connor's got this.
Go ahead.
No, we did not specify that they needed to wear anything special for the results. That is all.
So going off of that, did you have each participant do their sport-specific warm-up, or did you have them do like a generalized one? How did you kind of go about that to keep your results kind of consistent?
So the question was the athlete required to do their specific sport warm-up, or was it all just one specific warm-up? We kept the warm-up the same for everyone, and that was just to make sure everyone was doing the same warm-up, so there was no inconsistency with how it was performed. The majority of the warm-up exercises were pretty dynamic in nature, which is pretty consistent across athletes as far as their sports. They're all pretty active, so we just standardized it to make sure there was no inconsistencies there.
I might have missed this. How did you guys recruit? I know it was like campus, but how did you get the word out there? And what did you find was the most difficult of that process?
So you're asking about the recruitment process and how it went, pros, cons, that kind of thing.
I can take this one too.
Good.
The recruitment process was actually pretty difficult. So even though we reached out to the coaches and they reached out to their teams, we never really got any guaranteed recruits from that. It actually came from more of our personal connections with some of the athletes that we were able to recruit them. So if we could do it again, it would probably be better to go to each sport individually in person and recruit there with the coach's permission.
Hi there. Good job. Just a quick question, because you did a good job with describing your data, which certainly gives a normative point of context. So I think earlier you said something about the 90% threshold is the point where if you drop below that, you might see, it might be indicative of risk for injury. Is that correct?
So you're asking about the limb symmetry index
Yes.
percentage and whether or not if it drops below 90, if that is indicative of injury?
Injury or potential for injury, right? These are folks that are supposedly healthy, but if their index is going low enough, you flag them for potential intervention. So in terms of like a range, if folks take the data you have as the baseline of health, and those numbers start dropping, at what point do you think you might recommend some kind of intervention, and at what point would they be at serious risk? Is that range kind of determined where the bottom threshold is and the top threshold?
Sure. So I'm not aware of a specific bottom threshold for the limb symmetry index. I know that a lot of times the limb symmetry index is used for return to sport testing as well. So usually athletes are not cleared to return to their sport until they're at least 85 to 90% is usually like that upper limit or the, I guess, lower limit in that case. So in my personal opinion, anything below that 85% would indicate that there's a pretty significant difference between limbs, and that would necessitate a pretty significant risk of injury, especially for female athletes. The research has indicated, too, that if they have previously torn their ACL, they're even more at risk than males who have previously torn their ACL. So that's why we're using that specific measurement.
That's great. So if someone had surgery, is recovering, they reach that threshold, they go back to the sport, yes?
Yes.
So if your average athlete is being tested randomly, you start seeing those numbers come down, could that be an indication of potential risk?
Yes, that would indicate that they are potentially at risk, and at that point there would be potentially a recommendation made to have specific training to increase their limb symmetry index so that it's more equivalent, or potentially, if it's warranted, some physical therapy just to focus specifically on sport-specific exercises.
Awesome. Gotta go. Thank you much.
Thank you.
So below or beyond the warm up that everyone followed, were there any other physical factors that could have impacted the participants' performance in the jump?
So you're asking any other physical factors that might have affected a athlete's performance for us?
So yeah, the warm-up was great because we were able to kind of uniformly get a pre-exercise routine before the testing took place. Unfortunately, one of our larger groups, the soccer athletes, we were only able to get them immediately after one of their practices. So there's certainly a level of fatigue that could have factored into their scores. Fortunately for what we were finding with the limb symmetry index, that fatigue most likely affected both of their lower extremities in a similar fashion. So since we're comparing side to side, they should have fallen relatively equally. So the limb symmetry index should have not really, or at least if it was a factor, it was a negligible kind of impact on that score. Certainly a factor for maybe some future studies, whether they want to like look into specific how fatigue would have impacted it, find their limb symmetry index after a small warm-up, and then put them through a very structured exercise routine, and then find it once again after to see what kind of impact fatigue specifically could play.
Last question. So excellent job, group. And you know this is a little out of my area of expertise, but I really recommend, I think this would be a great presentation at a state conference, whether you choose a poster or a platform. But my question to you is, with this being a very strong pilot study, I think, did you have the discussion or have you thought about how you could expand on this, or future researchers, to get a larger N, and what would be, would that be beneficial?
So you're asking how we can kind of follow up with this pilot study, how to expand it, how to improve upon it, and make it potentially more useful. I can take this one. So yeah, we can definitely expand this. Our participants were only at Walsh University, so we could potentially reach out to other schools in the Northeast Ohio region to kind of create potentially then present at like a Northeast Ohio OPTA conference, should we choose to do that. There's definitely lots of ways to expand this to increase our sample size that we unfortunately weren't able to obtain right off the bat. But yes, that's one of the ways that we would use that.
Okay, stretch break, 10 minutes. We will start back at 2:35, 2:40.
Oh, when we first said it, the chair. Okay. I thought you guys wanted back. I'm sorry. That's okay. No problem.
Test.
Yeah? Enough room?
Is that if I do that, then they can stand and like see it out of the corner of their eye better.
All right, we'll go ahead and get started again. Pardon? Hello? Can they hear me? Can you hear me? Okay. We had a little change in setup. You want to pull that? Okay, I'd like to invite Zoe Puller and Kayla Richard up to the podium, and they will introduce themselves and their project once everyone's seated. We had a little change up here. That was for our audience who are virtual. We got some feedback on that, so we needed to do a quick change. All right.
Hi, my name's Zoe Puller, and I'll be starting off the presentation today on behalf of our group, which includes Kayla Richard, Chloe Berkey, and Catherine Tofelsky, as well as Dr. Hassan Miller, who was our mentor throughout this process. Today we will be talking to you about screening for social determinants of health in Ohio occupational and physical therapists. We'll start with some background about what social determinants of health are. These are the social and economic conditions of an individual's life that affect a wide variety of health, function, and quality of life outcomes. The U.S. Department of Health and Human Services developed a list of core objectives and initiatives to improve health and well-being over the decade. They identified social determinants of health as a top priority area. They stressed the importance of screening for and addressing social determinants of health across all areas of healthcare, including physical therapy and occupational therapy, in order to decrease inequalities and health disparities. There are 5 overarching domains of social determinants of health according to Healthy People 2030. The first is education access and quality. This includes factors such as language and literacy, high school graduation, and access to higher education. The second is healthcare access and quality. This includes factors such as health literacy and access to primary care. Third is neighborhood and built environment. This includes housing, crime and violence, and environmental conditions. Fourth is social and community context, which includes civic participation, discrimination, and incarceration. And lastly is economic stability, which includes employment, food insecurities, and poverty. So why is this important to us? Studies suggest that an individual going through musculoskeletal recovery is only influenced 20% by the medical care that they receive. This means those other influences, which include 40% social and economic factors, 30% behavioral patterns, and 10% environmental conditions, are largely these social determinants of health that we're talking about. Social determinants of health are associated with higher incidences of chronic diseases, such as arthritis, diabetes, and heart disease, and can affect an individual's motivation and compliance with care, affecting their overall prognosis. Imagine for me a patient receiving wound care from a therapist, and they discover they don't have access to nutritious foods. This can impact their healing. Or imagine for me someone receiving outpatient therapy, and the therapist discovers they don't have a car or access to public transportation. The likelihood of them being able to come into the clinic for the level of care necessary is low. As occupational therapists and physical therapists, these things are important to screen for and address with our patients in order to help them achieve the best outcomes. The American Occupational Therapy Association and American Physical Therapy Association acknowledge the importance of identifying social determinants of health in individuals seen by these professions. The purpose of our study was to investigate if and how frequently Ohio occupational and physical therapists are screening for social determinants of health in their patient populations. We developed a survey which was sent to occupational and physical therapy educators to be checked for content validity. We then identified 18,416 actively licensed occupational and physical therapists in the state of Ohio and electronically delivered the survey. The survey was open for 5 weeks, with reminder emails sent out on average once per week. After the survey closed, we used SPSS to analyze the demographic data, frequency data, and the cross-tabulations between the two. Demographic data we collected included which profession they belonged to, if they were a member of their respective national organization, if they had a postgraduate certification or specialization, their highest degree earned, their practice setting, if they had any clinical affiliations, and how many years they've been practicing. We then asked questions about their screening habits, which included whether or not they performed initial evaluations as part of their job, how often they were screening for social determinants of health, if they were using this information about social determinants of health when establishing a plan of care, what barriers they experienced to screening for social determinants of health, what method they used to screen, if they used any specific tools, and what were they doing with this information, and were they addressing it with their patients. I'll now pass it on to Kayla to discuss our results.
So we had 1,639 responses with a response rate of 8.9%, and the majority of our demographics had a good distribution. But of note, we had approximately 2/3 of respondents who were practicing PTs versus OTs, with the majority of them not being a member of their national association. And then over 2/3 didn't specialize beyond their initial degree, which the majority were either a master's or a doctorate degree. And more respondents practice in the outpatient setting than any other setting, with over half being in a hospital or healthcare system. In Figure 1, we're looking at how often therapists screen for social determinants of health, and 35% of all the OTs and PTs that we surveyed said that 35% of the time they always ask about social determinants of health. Okay. So there's going to be a few tables going forward, and in these they're split into two categories. On the left half, it reports the data from those therapists that screened for social determinants of health less than half the time, and then the other, on the right side, it's those who screened greater than or equal to half the time. Looking at the relationship between the two professions, the majority of PTs and OTs did say that they were screening, which is a good thing. And Figure 2 illustrates how often therapists use the social determinants of health information they collected to help establish their plan of care. And in Figures 1 and 2, we can see that the majority of respondents were completing a screen and then were using that information to establish their plan of care. And looking at the barriers to screening, there wasn't one specific area that therapists reported had limited their screening more than another, but 1/5 of respondents did report that they always asked about social determinants of health regardless of the barriers. And then you can see that the highest rated barriers were that the therapist didn't have the tools or resources that they needed to screen, and then either the therapist or the patient wasn't comfortable. And it should be noted that from this figure that the results were reported as a percent of responses rather than a percent of respondents, because the participants were able to select more than one question or one answer. We also found that therapists said that they use the information they gathered on a patient's social determinants of health screen either to make a clinical decision 26% of the time, or to address directly with the patient 41% of the time. Those were the two highest rated categories. In this table, we can see that across practice settings, home health respondents reported screening at least half the time, approximately 10 to 15% more than any of the other settings. It's highlighted there on your screen. In contrast, those working in schools and military settings were the only areas demonstrating a greater percentage that were screening less than half the time. Among different degree levels, the majority of all degrees said that they screened at least half the time. However, those with a Doctor of Science, Education, and Philosophy, they demonstrated a 15 to 20% more respondents screening at least half of the time. And this table, those that had a post-grad certification or specialization demonstrated an overall small increase in the percentage in asking about social determinants of health at least half of the time. With this, of those who underwent a residency program, there were 0 respondents who reported that they never screened for social determinants of health. And then, in addition, greater than half of those who were in a fellowship program reported that they screened all the time. This study overall provides a glimpse of the frequency and consistency that OTs and PTs are asking their patients about the disparities in health that they face. Overall, there was a consensus that screening is important and that the majority of therapists are doing it. In addition, the vast majority of those who are screening are then using that information to develop their plan of care, which is great. A few aspects to note include the low screening rate in the schools and military settings and the high screening rate in the home health setting. Potential reason for the low screening rate in the schools and military settings is that in the military, patients often have a high level of direct access and on their military base. And then in schools, children are also followed by multiple members of the interdisciplinary team. So OTs and PTs may not find it as necessary to directly ask about their patient's social needs. Also later we'll talk about the low response rates that we had in these settings, which could also contribute to that. And with a high screening rate, 11.8% more therapists in the home health setting said that they were screening for social determinants of health greater than half the time, more than any other setting, which could be because they're directly in a patient's home, so they're able to view what their living and social conditions are like, so then they can ask and meet the needs that they need because they're able to view that. Our findings also support the current research that providers believe that looking at social needs is an important part of holistic care, and it also echoes that barriers do limit providers' ability to screen, which includes the therapist's lack of time, tools, resources, and training necessary, as well as discomfort from either the provider or patient perspective. And in a study by Morrison et al., it was found that healthcare workers feel at ease through sufficient training in social history taking and in addressing these issues in clinical practice, as well as through sufficient education of local referral sources. They're more likely to broach these sensitive issues and then refer their vulnerable patients to the proper sources, which is why we believe that it is important for schools to incorporate social determinants of health screening into OT and PT coursework. That way we can better prepare our future clinicians to be able to address and help decrease inequities and health disparities. A few strengths. OTs and PTs often work together in clinical practice, so the sharing of knowledge and practices between the two professions can help patient outcomes, help enhance patient outcomes. And then to our knowledge, this is the first study to analyze whether OTs and PTs are screening for social determinants of health, as well as the only study conducted specifically in Ohio. There were a few limitations to our study, one of which was when we sent out the survey, it was labeled as social determinants of health, which can create some response bias because those who click on the survey may have a strong opinion one way or the other. So they might feel strongly that we should be screening for social determinants of health all the time, or they could feel strongly that it does not matter. Due to this, there could be respondent bias and may not actually match the opinion of the population. In addition, there were low response rates from those in the military, those that participated in a post-grad residency and fellowship, as well as those who received their Doctor of Science education and philosophy. So that could create a positive or negative skew and also not represent the greater population. And despite defining the categories of social determinants of health at the start of our survey when we sent it out, it did seem apparent from the qualitative data that respondents interpreted as social determinants of health to include contextual factors beyond what was listed. That included mental health factors like depression and anxiety, as well as patient medical conditions. This may have resulted in an inaccurate representation of the number of respondents that were actually truly screening for social determinants of health. And finally, we used the Likert scale in our answers to show the difference between the categories. However, that's an ordinal level of measurement, which we were not able to attain p-values from that data, and it prevented us from saying whether any of the patterns we identified and measured had any statistical significance. And then moving forward, additional studies should be conducted to investigate if therapists and healthcare providers are getting a true assessment of social determinants of health, as we were unsure if, those that replied to our survey were doing so. They should also delve into the specific barriers that patients and providers perceive when social determinants of health are involved due to the sensitivity and stigma associated with it. In addition, a systematic review looking at the specific screening tools used in practice would be helpful to help increase awareness and the utilization of social determinants of health within the healthcare field. And then finally, further research should look into the thoughts, perceptions, and beliefs that therapists have in regards to social determinants of health, and then if that impacts their screening habits, as well as their ability to address that with their patient. On April 5th, we submitted our manuscript for review to the Internet Journal of Allied Health Sciences and Practices, and we're awaiting further feedback from them. Here are our references, and we'll open the floor for questions.
Excellent project. Question about your return rate. That is always a challenge when doing a survey research, but maybe I zoned out, but how many times did you send it out, and did you like send reminder emails? Just curious.
Yeah, so the question was about how many times we sent out the survey and kind of sending out reminder emails to get more respondents. So we sent out the survey initially, and then we sent it out again every week for 5 additional weeks. Or, well, it was open for 5 weeks, and we sent out a reminder email each week for 5 additional weeks. So they should have been getting emails 5 to 6 times.
And I assume the emails had the link so that if they deleted the first one, they could click? Okay.
Yes.
Thank you.
Yeah, so I kind of have a twofold question. So I just want to have a better clarification on kind of how the survey was set up. Was it kind of like, do you ask social determinants of health questions, yes or no? Or was there like a minimum that you have to hit to determine like whether you asked enough questions? Like for my example would be, if I was like in an inpatient setting and I know that they can't get to outpatient because they don't have a car, because I've addressed that with them, did I do enough to address social determinants of health, or is there like a minimum requirement to suffice?
So Caleb was asking about kind of the setup of our survey and how we asked how they screened. It was about a 20 to 25 question survey. That our first question after defining what social determinants of health were just kind of straightforward, do you screen or do you not? And we didn't provide a minimum, or we didn't provide a definition of what we defined screening as. We kind of left that up to the clinician. But then throughout the survey, we asked more questions about, you know, if you do, how do you do it? If you don't, why don't you? And things like that, that had multiple answers that they could select multiple. And then we also had a few text box answers that they could write in why they didn't, or barriers. So we kind of left it general, and then through our survey asked some more questions to get some more details.
I just had a quick question about, did you guys notice any screening tools that were used more often than others, or certain ways? You knew that was coming, right?
So we had a question about the screening tools and if there were some that were more than others. Unfortunately, we didn't get any great screening tools. The one that was most said that therapists use was the Promise 29, which is often used for occupational therapy. But there weren't any really good screening tools that we could identify and then look into the literature that looked specifically at social determinants of health, unfortunately.
So I'd like to welcome to the podium Beth Myers and Brooke Miller to introduce their group.
Hello, everybody. My name is Beth Myers. Our group is consistent of Brooke Miller, Caitlin Zuroff, Sean Sweeney, Colin Cottrell, and Dr. Ryan Monty. The title of our research is The Assessment of Shoulder Strength Percentage Ratios in High School Age Softball Players Utilizing an Externally Fixated Digital Handheld Dynamometer, a Pilot Study. Within our literature search, we discovered that one of the underserved populations were youth female athletes. In physical therapy, we tend to be a tertiary service, meaning individuals seek our help after an injury. What if we could assist a population before an injury, and how would this look? Within female athletics like softball, a lot of literature surrounds the windmill pitch. However, articles such as Bonza and Fort Holm argue that overhead throwing is just as detrimental in the event that there's improper muscle balance. With that being said, shoulder injuries are the 5th most prevalent injury within softball. As we delve deeper into the literature, we are seeing support that decreased muscle strength may be a large contributor. Lower shoulder strength percentage ratios have been associated with pain in not only softball, baseball, but also handball players. Risk of shoulder injury increases when a player has a history of injury, increased training load, lack of or excessive range of motion, and rotator cuff weakness. However, there is limited research on shoulder external rotation and internal rotation strength percentage ratios and their prevalence in shoulder injuries, specifically in high school age female softball players. So before I move on, I want to talk a little bit about the terminology that you'll be seeing throughout this presentation. When you hear the word internal rotation, I want you to think of somebody throwing the ball. When you hear external rotation, or ER, I want you to think of winding up or throwing the ball. And lastly, when you hear strength percentage ratios, this is external rotation, or ER, divided by internal rotation, or IR. And essentially, these ratios are very important to assist in determining if injury has either occurred or possibly can occur. Typically, we see greater injury during the deceleration phase of throwing, meaning if the ER and IR rotators are too weak in our shoulder, they may be able to, or they may not be able to combat the force, therefore leading to an increased risk of injury. The rotator cuff muscles are not only responsible for the movement of the shoulder, but also stabilization of the humeral head within the fossa. Balance of these rotator cuff muscles is required to maintain glenohumeral congruency. However, in overhead sports, muscular adaptations due to the demand of the sport may create an imbalance. An article by Wilk et al. Reported that ER and IR shoulder strength percentage ratios for older adults as a predictor of injury was approximately 66 to 75%. These values have also been supported by similar strength percentage ratios seen in junior tennis players, professional baseball players, and healthy subjects. The goal of our study was to bridge the gap in literature to not only measure shoulder strength percentage ratios, but to also determine if there's a correlation between strength and balance and throwing with pain in high school softball players. In order to measure this, we used the Kerlan-Jobe Orthopedic Clinic Shoulder and Elbow Score Questionnaire, also known as the KJOC. This is a validated patient-reported outcome measure used in overhead athletics. It uses 10 questions on a visual analog scale of 100 millimeters, and it is specific to the shoulder and elbow for overhead athletes. A cross-sectional study by Holtz and O'Connor evaluated 53 softball pitchers aged 12 to 18 and determined that pitchers with a preseason score of less than 90 out of 100 on the KJOC had a 3.5 times greater risk of injury during in-season. Moreover, one study determined that asymptomatic professional baseball players scored greater than 90 on the KJOC, indicating that healthy overhead athletes would score over 90. The testing position that you see is external and internal rotation strength at 90 degrees of glenohumeral abduction, and it's advantageous as this position is specific to the true pattern of overhead movement. It not only protects the anterior capsular glenohumeral ligaments, but it also enhances a link tension relationship of the posterior rotator cuff. These are common recommendations for muscle testing that involve positioning the joint also at the midpoint of active range of motion, which would be 45 degrees of external rotation of the shoulder, as this would produce optimal muscle contractions. Our purpose was to assess the intra-rater reliability of 90 degrees elbow flexion, 90 degrees of shoulder abduction, and 45 degrees of shoulder external rotation, also known as the 90-90-45 testing position, while using a digital handheld dynamometer externally fixated device. more so to collect data on dominant throwing shoulder ER and IR strength percentage ratio, and if there's reports of throwing with pain. A little bit more into our methods. We were recruiting females that were 14 to 18 years old. They had to plan to participate in organized softball during the 2022 spring and summer seasons. IRB was obtained through Walsh University, and we had a miraculous sample size of 5. Exclusion criteria included males, players who also participated in sports not including softball during spring and summer season, players who initially scored less than 90 out of 100 on the KJOC, which would indicate compromised sports participation, players who only participated in softball pitchers, and or players that have a history of surgery on their shoulder or elbow. So this is a timeline of our 8-month journey of recruitment and how we got them 5 subjects. It all began January to February in 2022. We began contacting local schools' administrative directors to educate them on our study. Of course, we weren't able to distribute our flyers just yet because we did not have IRB approval. Following in February and March, we finally gained that approval and we were able to distribute flyers to coaches and schools. February to April 22, we met with varying softball teams and were able to educate them as well as start setting up testing dates. April through May, we distributed flyers to varying training facilities in Stark County, as well as practicing softball teams, and we got approval to post on social media. April through June, we began testing at Walsh, as well as local high schools. And finally, in August, we administered our post-softball season KJOC follow-up phone call. So I won't stay on this slide long because I want to show you guys pictures just to give a full sense. But testing required about 45 minutes to 1 hour of the subject's times. They first began performing a multi-planar warm-up with TheraBands, and then from there their ulnar length was measured in order to standardize our data. The patient was seated, back supported, and then one person from our team, Sean, was able to measure and position the shoulder at the 90-90-45. There was a belt, and I'll show that. So if you see here, the belt was actually established at 90 degrees of the upper extremity to make sure that was neutral. And then from there, the digital handheld dynamometer was placed 2 centimeters above the ulnar styloid. Each subject performed a total of 6 contractions. 3 contractions were external rotation and 3 were internal rotation. They had 2.5 minute rest break in between each contraction. They had a 2-second ramp time, and they had to hold that contraction for at least 5 seconds. So if you look up here in picture A, you see that Sean has to stabilize the external fixated device, otherwise it would fall and it's extremely expensive. But he did not provide any external force. Therefore you see B, when he's not holding it, you see it falling off. And then if you look down at C, that is us testing external rotation, and D is us testing internal rotation.
All right, if you see here, this is a little bit more about our 5 subjects. So all 5 subjects were right-handed. There was an average age of about 15 years old. We had 1 catcher, 3 positional players, and 1 player who participated as a pitcher as well as a positional player. This table represents our average preseason and postseason test results. Looking at the right side of the chart, you can see that both pre-test and post-test KJOC scores were above that 90 out of 100 threshold, indicating that all athletes were not throwing with pain before or after their softball season. Looking at the left side of the chart, you can see we have ulnar length and our values for shoulder strength. As mentioned in the previous slide, ulnar length was taken to standardize the strength percentage ratios due to the significance of bone muscle asymmetry in youth athletes. After averaging the rotator strength values for each individual, external rotation strength and internal rotation strength were each divided by ulnar length, then the ER to IR ratio was determined. In this study, the average ER to IR ratio was 77.6%, which you can see in that middle column. Compared to previous studies assessing shoulder rotator strength, our research revealed similar average ER to IR strength ratios to those reported in male collegiate and male professional baseball players, which is commonly reported between 63 and 78%. Normative data that is available for shoulder strength ratios in female softball players and other female overhead athletes tends to be reported higher in the literature at 91 to 102%. Individual data from each subject we tested is listed here in this slide. While I stated that the average percentage was 77.6%, as you can see in that first circle, the values did range in our study from 53.5% to 98.3%, indicating that there was some variability between our high school subjects. It is worth noting that one subject, subject 2, did report throwing with, quote, soreness on the second KJOC question, which asks, how much pain do you experience in your shoulder? She also reported difficulty warming up prior to playing on the first KJOC question. She demonstrated a lower shoulder strength percentage ratio than the reference value for predictor of injury, which is commonly reported at 66%, and she demonstrated a ratio of 64.4%, as you can see circled in red. However, her total KJOC score did not indicating throwing with pain, as she was above that 90 out of 100 threshold, scoring 98.3 in her post-test. Overall, all of the subjects reported throwing without pain, regardless of their preseason ER to IR strength ratios results. So those that had scores above and below that 66% had similar KJOC scores. Inter-rater reliability for the 90-90-45 testing position was determined using the interclass correlation coefficient, or the ICC model. Inter-rater reliability was rated as good, as you can see circled in red. The ER ICC value was 0.831, and the internal rotation was 0.852. Thus, this is reliable when testing with the same tester at different points in time. These findings provide a reproducible method for testers to quantify shoulder strength in a position that mimics their throwing position. Inter-rater reliability of this testing position revealed similar reliability results as a study assessing shoulder rotator strength, also with a handheld dynamometer and externally fixated device, but with the patient standing with the arm at their side, elbow flexed to 90 degrees, and the forearm in neutral. So it would look more like this, and so the throwing position like this, which is how we tested. So to summarize the study results, the 90-90-45 testing position demonstrates good inter-rater reliability for testing shoulder rotator strength. Additionally, the use of an externally fixated digital handheld dynamometer to measure shoulder rotator strength in this position is reliable, and it's pretty feasible to reproduce. Second, lower shoulder strength percentage ratios still may be correlated with throwing with pain, but we're unable to draw a conclusion due to our low sample size. So our main limiting factor was our small sample size. This may be due to multiple reasons. Due to the timeline of our program and our study, we were trying to get subjects right before their season had started, so they had started practicing or they were still in conditioning, and then also went through towards when tournament time was ending, so there was a quick turnover between spring season and summer season, so it was hard to get a lot of subjects to follow through. An additional limitation was lack of randomization in our study design. And while subject 2 did report soreness, her KJOC score did not reflect throwing with pain. And then finally, to keep the handheld dynamometer in the proper position, the tester did need to stabilize the dynamometer, but he did so without providing an external force. So in future studies, if we can find a way to truly fixate the device, this will make up for that limitation. On to strength. So our study did support the inter-rater reliability for that 90-90-45 testing position, and also using the externally fixated handheld dynamometer. Additionally, there is a possibility that shoulder strength percentage ratios may predict throwing in pain in the specific population of high school softball players. But again, as I said, more studies need to evaluate this. And again, future research should expand on these findings. We did develop a pretty feasible protocol to reproduce in this position and using the handheld dynamometer with this device. The knowledge gained by this study and other studies focusing on shoulder strength in overhead athletes, specifically in female athletes, can improve educators' knowledge on training tactics to prevent injury and pain. This may include educating players, coaches, trainers, etc., and appropriate warm-ups and strengthening programs to conduct. Lastly, again, a larger sample size is needed to promote the justification of a correlation between shoulder strength and pain in this population of athletes. And then we did create a poster that we presented at East Central District in Youngstown State. There's all of us. And then here are references. Any questions?
All right, first off, I want to commend you guys for creating a protocol and going to the extensive length to do that, because that's an impressive thing to do. Obviously, you've stated multiple times that your sample size being so small was a major limiting factor. Looking back on the whole process, is there anything other than what you said that you consider to be a limiting factor, or any advice you would give to future even students trying to replicate this study and protocol so that they could get more subjects?
So the question is just talking about our limitations with our sample size and if there's anything that we could do better for future cohorts.
So I thought across the board we did a pretty good job of communicating with schools and neighboring counties about subject recruitment. Our IRB was kind of delayed, which kind of got us a late start. And then we had to go through the principal or the superintendent before that got transferred to the coach and the players and their parents to get approval. So if we got, it was kind of a chain of command thing. If we didn't get approved by the superintendent, or if they didn't reply to one of our emails or phone calls, we couldn't go farther with that school. And then some schools did tell us yes, and then like we would continue to contact them and they didn't get back to us because of just that loss of communication there. So I think just getting I think we did our part with that, but I think it'd just be continued trying to get it IRB approved faster and getting in contact with the schools faster, especially because they're ending school around that same time we were contacting them. So a lot of people had a lot of stuff on their plate.
So I'd just like to say great job. My question is, during the testing process, how are you able to maintain that 90-90-45 position that you guys were looking to test? And then furthermore, did you guys feel like either internal rotation or external rotation was harder to stabilize, maybe one more than the other?
So the question is just asking how we maintain the 90-90-45, and if so, how were we able to do so, as well as if external or internal was more or less difficult.
So each subject was pre-measured in that 90-90-45 position with a goniometer before each trial. So like she said before, there was 3 trials in each position, so they were pre-measured each time to ensure that they were in that position. And then the second question was about...
Is ER or IR harder to stabilize or not?
Internal rotation was definitely harder, just typically with most humans that were stronger in internal rotation due to our pecs and lats and things like that. I would definitely say, just as an anecdote too, with a lot of the subjects, it was definitely harder to do internal rotation, especially when you had sisters that were 2 subjects in competition between teammates. So it was definitely a lot harder when they started pressing a lot harder into internal rotation.
Okay, I echo the nice work on all of this, on all the hard work. So looking at the externally held device, and so it requires another person to do this. So thinking ahead as an entrepreneur, potentially in Shark Tank, could you think of an adaptation to maybe make the tool more self-sufficient, so to speak?
So he's referring to Shark Tank, and if we would like to sell equipment one day. No, he wants to know if there's any way that we could like MacGyver equipment essentially to make this more productive.
So that was a problem we kind of ran into during our study, figuring out if we wanted like a person to stabilize it or some sort of like place to put it on. It was something we kind of went back and forth about, but we ultimately just decided to have one person do it. But it was definitely something we talked about, like either fixating it on some sort of pre-made device or fence, something like that we wouldn't move. But it's just something that we never got around to creating. So maybe it'll be on Shark Tank one day. You have to look out for it.
All right, last but certainly not least, we welcome Caleb Graveldugger and Ethan Donner to the stage, and they will introduce their project.
Hello, everyone. My name is Caleb Graveldinger. I'm the lead investigator for our literature review project, researching the effects of inspiratory muscle training as an intervention for reducing pain and disability in patients with chronic low back pain. Presenting our project today will be myself and Ethan Donner, who is a fellow researcher on this project. The other project researchers, Kelsey Fiorello and Tyler Missler, will be answering questions following the presentation. Dr. Jamie Paz was our project mentor. We selected the population of chronic low back pain as our population interest because of its high prevalence in today's society. Currently, chronic low back pain, which you'll see abbreviated as CLBP throughout the presentation, is estimated to have an occurrence rate of 5 to 36.1% in the general population. As age increases to over 50, this prevalence rate increases by 3 to 4 times that. Because of the high prevalence rate and its impact on healthcare costs, research regarding alternative interventions is necessary to address the variety of presentations. Other than traditional exercise, other methods of treating it include yoga, tai chi, and interventions that focus on breathing retraining. But how does breathing impact low back pain? The muscles that are effective in breathing are synergistic with muscles that are involved with lumbar stability. In the case of lumbar stability, imagine, if you will, the abdominal region acting like a soda can. The abdominal and multifida muscles make up the walls of the soda can, the pelvic floor makes up the bottom, and the diaphragm makes up the top. Together, they maintain intra-abdominal pressure to create lumbar stability. The diaphragm is critical, as is the primary muscle of inspiration. It, along with the accessory muscles, are responsible for altering pressures inside the abdomen to affect respiration. However, weakness of this muscle can lead to decreased intra-abdominal pressure and, in turn, decreased stability, which inherently leads to chronic low back pain. So how do we strengthen this muscle group? We use a technique called IMT, which stands for inspiratory muscle training. Resistance is applied through an external device that overworks the muscles of inspiration, leading to overall strengthening and improved function, which is why it's commonly used in pathologies such as asthma, COPD, and bronchitis. To establish a baseline strength measure, the device that we selected measures PI max, which stands for maximal inspiratory pressure. This is determined by evaluating the highest possible pressure that can be sustained by the device over 1 second and then average over five trials. Once this is established, it allows the user to target percentages of it for training purposes. This is the Power Breathe device that all the studies that we included utilized, and is the primary IMT device that is used. Therefore, the purpose of the study was to describe the existing evidence regarding the use of inspiratory muscle training as an intervention for reducing pain and disability in patients with chronic low back pain. Our research hypothesis was that IMT is an effective intervention to reduce pain and disability in patients with chronic low back pain. To clarify our research, we defined IMT as an intervention focused on improving the muscles of inspiration using an external device. And chronic low back pain was defined as pain in the lumbar region that has persisted for a minimum of 3 months with no specific cause.
So Caleb and I are going to tag back and forth a little bit here as we go through the methodology and the results and the discussion of our literature review. Up on the screen here is the methods that we use to search the databases. Listed on the left, PubMed, CINAHL, ProQuest, etc. are examples of online databases that we use to search. And then the right side of the screen is the eligibility criteria for inclusion and exclusion that we use to determine what articles were or were not appropriate for our study. So we were mainly looking for at least 18 years old for participants that had chronic low back pain that was nonspecific for at least 3 months. And like Caleb had previously mentioned, nonspecific means no specific mechanism of injury, no previous pain from surgery, etc. We wanted randomized control trials that were published after 2012, and we wanted them to have a primary outcome measure within the article that measured either pain or perceived disability from the back pain. And the exclusion is essentially everything else that does not fall in the inclusion criteria. This is the terms that we used to put in our search query. Low back pain has mesh terms and text terms. The mesh terms are essentially just subject and heading terms, and then the text terms are terms found in the text of the articles. And it's the same for the inspiratory muscle training on the right. It's just different ways of saying the same thing. When we ran our search through PubMed, we found 156 potentially relevant articles. We were able to initially exclude 2 of them immediately because they were duplicates of each other. They just popped up the same, so we got rid of those. And then we used quick abstract reviews, just the summaries of the articles that were posted, to determine if they were appropriate before we decided to go into a full text review. In doing the abstract reviews, we were able to eliminate 147 of them because they were not a randomized controlled trial. The participants were wrong for what we were looking for. They did not search for a pain or disability outcome measure like we wanted, or they were not published in English. After that, we had 7 articles that were available for a full text review. We read through them. 2 of them were excluded because they did not assess pain or disability through an outcome measure, and one was excluded because it was not true inspiratory muscle training. It was just a diaphragmatic breathing exercise. This left us with 4 randomized controlled trials to use for our study. This slide and the next slide are the population demographics of those 4 studies. With a randomized controlled trial, each participant pool is split up into 2 groups, the control group and then the experimental group. And as you look through this, we would highlight it if there was, but there's no glaring differences between the control group and experimental group for each article in terms of age, height, body mass index. These are the next 2 articles. You can see the same. There are no glaring differences between either of the demographics for the articles or the groups. This slide indicates the assessments that were used and then overall study population through the 4 articles. All 4 of the studies looked at pain. 3 of them used the visual analog scale, or VAS for short, which is essentially a 0 to 10 visual scale. 0 has a really happy face, I have no pain. 10 is a really sad, crying, angry face, I have the worst pain imaginable. The NRS scale is the numerical rating scale. It's the same idea, just 0 to 10, but it's a verbal rating scale. How do you feel? 0, no pain, 10, the worst imaginable. 2 of the articles looked at perceived disability through the ADI, or the Athlete's Disability Index, or the ODI-2, the Oswestry Disability Index, second version. Our study population overall was between athletes and non-athletes, the athletes being weightlifters, powerlifters. And again, this was included in our inclusion criteria, but at least 3 months of chronic low back pain. All of the 4 studies utilized some form of a power breathe device for the inspiratory muscle training device. As you can see, they're a little bit different, but it's all by the same base model, and all of the intervention parameters are listed up there for what they did for the study. They were all basically exactly the same, which allowed us to compare them together. So the first article here is by Janssens et al. They had 28 participants, and they were split into a high inspiratory muscle training and a low inspiratory muscle training group. The high group wanted to reach a 60% of their PI max, as Caleb had previously explained, and the low inspiratory muscle training group, a 10% of the PI max. They focused on multiple things, but we were looking for the Oswestry Disability Index and the numerical rating scale for their outcomes. This slide and the next couple slides that we go through with the tables of the results have p-values highlighted. Those are what are considered statistically significant. And a p-value is just a statistic that determines if the outcome that occurred was by chance or not. Lower p-value means it was likely not by chance, it was likely a correlation to the intervention that was performed. You can see through the high inspiratory muscle training group that is highlighted, there was a low p-value, not as much with the low inspiratory muscle training group. And when you compare them together, there was a difference between the high group and the low group compared to each other. That is not the case with the Oswestry Disability Index. There was a decrease in pain, but it can't be considered statistically significant. With Finta et al., there were 47 participants. The control group performed general strengthening exercises of the core, trunk, hips, and then the diaphragmatic training group performed all those same strengthening exercises along with the inspiratory muscle training at 60% of their PI max. They also measured multiple things, but we were mainly focused on the pain via the VAS scale. Both groups actually had a p-value that correlated to significant. They both were able to decrease their pain over the 8-week threshold, with the control group actually showing a decrease in pain greater than the diaphragmatic training group. And we can't exactly speculate as to why that is, but they also measured something for core musculature thickness via ultrasonography, and that was greater with the diaphragmatic training group, whereas the control group had no change in their core musculature thickness. So we could assume that over time, that increased musculature thickness would lead to increased strength and stability, which would decrease pain over time, but that's only speculation. I'll just step back here.
This study was conducted by Borgeni et al., and the primary difference with this compared to the previous two studies is that its primary population was weightlifting and powerlifting athletes. The control group performed their standard weightlifting exercises, while the experimental group did this, plus IMT with the power breathe device. The outcomes we focused on in this study were pain, measured via the VAS scale, and disability, measured via the ADI. As you can see in the above table, pain was significantly improved pre versus post intervention. However, these significant differences were unfortunately not seen within the athletic disability index. This study, conducted by Ahmad Zed et al., also had a primary population of weightlifting and powerlifting athletes. Similar to the last study, the control group performed their standard weightlifting exercises, while the experimental group did this, plus IMT with the power breathe device. PI max was gradually increased throughout the study at 5% per week, up to 90% PI max at the end of the study. There were many outcomes, but the primary outcome we focused on was pain, measured via the VAS scale, which showed statistically significant within group differences, which means that they showed before and after effects, as well as this was statistically significant compared to the control group. So to recap, we had 4 RCTs that evaluated pain and disability using a power breathe device. 4 studies directly measured pain in some way, and all 4 showed significant pre versus post-treatment effects. However, the 2 studies that measured disability showed no significant impact on disability levels. This reveals a potential relationship between inspiratory muscle training and chronic low back pain. These findings are consistent with the literature on this intervention. A systematic review by Usman et al. Reported that they were able to determine significant impacts in pain and disability through the use of IMT. However, it's worth noting that they expanded their definition of IMT to include interventions that train the muscle inspiration in other ways. The question then becomes, is solely IMT effective at reducing low back pain, or are all respiratory interventions equally effective at reducing low back pain? We were unable to find any studies that directly answered this question. And while the findings are also consistent with the current literature on IMT, the current literature is somewhat sparse on IMT. A study by Tilgan et al. Evaluated the effectiveness of breathing exercises on mothers with the intention of determining if significant effects were seen with IMT as combined with other interventions, in this case, core stability. Both groups showed significant within-group differences. However, no between-group differences were identified. This reveals a potential gap in the literature regarding whether IMT is an effective standalone intervention, or is it only effective when combined with other interventions? And is it more or less effective when compared to other standalone interventions that work to strengthen the muscles of inspiration? No studies were found in our search that directly answer this question, indicating a need for future research on this.
So as with any study, ours is not without limitations. We had only one of the 4 studies that we found report an effect size. So the p-value determines if it was by chance or not, and the effect size determines the magnitude of the size. So it really makes it applicable if you want to use this in your everyday practice and how this statistic is useful to you. Overall, we also had a small sample size of 212 participants across our 4 RCTs. Therefore, we cannot generalize it to the whole population based on just that. And none of the studies assessed the effective comparative effectiveness to other breathing retraining interventions. For the intervention itself, appropriate training is required to use an IMT device, as this is stressing the inspiratory muscles. And if a person is not an appropriate candidate for such treatment, then you could cause respiratory distress. There's also a financial barrier to purchasing and utilizing the IMT equipment. In conclusion, we reviewed 4 randomized control trials to determine if intervention of IMT reduced pain with nonspecific low back pain or reduced disability with nonspecific low back pain in the non-athletic and athletic populations. All of them used a power breathe device for the inspiratory muscle training, and chronic pain levels were reduced in all 4 studies. More research is required so that we can view IMT versus other breathing retraining interventions or non-breathing IMT-based interventions. And it's also important that we get an increased sample size so that we can generalize it to the whole population. Our disclosure statements, and also the last bullet point is for our peer-reviewed dissemination. We are submitting to the Ohio Physical Therapy Association Fall Conference in September of this year. This is the specific search query that we use to find all of our articles. And the next couple of slides are just all of the text references that were utilized, and then the image references. And now it's time for questions.
Very nice job. So I noticed within your sample, the age ranges were mostly in the 20s. So was that intentional? Were you looking for a specific age range, or were you surprised by that?
So to clarify, the question was that in our sample, or in our studies that we viewed it, the age range was lower, and was it intentional or not? Fortunately for us, no, it wasn't intentional. As Ethan and Caleb mentioned, the available literature was very small, so those were just the studies that were available to us at this time.
I'm not sure if I missed this, but I was just curious, of the 4 studies that you guys looked at, was there any type of extended follow-up for the patients?
So the question was, out of the 4 studies, was there any extended follow-up of the patients, so following the intervention? To my knowledge, no, there was not. It was just like an 8-week period in all 4 studies, and there was nothing reported after the 8 weeks, so post-intervention, anything outside of that 8-week range.
While conducting this literature review, did you guys find yourselves using IMT out on your clinical rotations? Because I know chronic low back pain is pretty common.
So the question was about, after concluding this research, have we as physical therapists, student physical therapists at this time, started to use IMT for low back pain in the clinic? I personally have not. I definitely have had patients who could have benefited from it. And I think it's definitely something I'll use moving forward if I, can get more appropriately trained on it and we have the equipment, because I do feel it's an important piece to the puzzle. I feel like the diaphragm is definitely a forgotten piece in the chain that we don't work on fixing enough.
How about that? You're done. Give yourselves all a round of applause. All right, so now we're going to take a break. We will reconvene at 4 o'clock. There are some refreshments out to my left, out in the atrium. Please get yourself something to drink, something to eat, and we will come back at 4 o'clock for the graduate celebration.
They would step down, I would imagine.
Well, they can come up. We have all this room, so.
Yeah. You want them on stage?
That way there's less to do.
I know. There are a lot of courses.
No problem. Do you want, is that okay?
Yes, I put the
It's all right. Of course, my pleasure. I should have worn the name tag, me too. Okay.
Yes, they come back. Anything else that you need?
Is there anything I can help you guys with?
We are ready.
What?
We are a well-oiled machine.
I'm sure you are. How long have you been here?
20 years.
So you've done this a time or two.
Once or twice.
Yeah.
So, yeah.
Wow.
Best day of the year.
This is great.
Then I cry at graduation every year.
I'm sure.
Every year. Because they're my children.
I'm sure.
They're my little
You get
kids.
to know them so well.
Oh my gosh. Well, they're here for 3 years.
Yeah.
And they come as a group and leave as a group. So, you know, they're little families. Each group of them is a little family. So, go have a snack if you want.
Thank you. I might do that. Okay. Wow. On the other side too?
There's the buffalo tree with food.
Thank you very much. Appreciate it. Just because you have a whole room. Sure. Here, I'll take this. You can.
Let's see. I just want to make sure it's not going to fall apart. Yeah, because we actually, I talked to, it's in two, just so it's all in one single location. Right. We just, they originally actually.
Until you're
then tap again when you're live. Yes. And then just press and hold shut.
Welcome back. So we are here now to celebrate our DPT class of 2023. So I want to welcome all of the graduates, soon-to-be graduates, their family, their loved ones, and the faculty and administration. We are so proud of our 32 graduating students who selected Walsh as their university for their physical therapy program and to become leaders in service to others. These students are among about 2,300 students who hail from 37 states and 24 countries at Walsh University. Walsh's mission is to offer a values-based education in the Judeo-Christian tradition, and our program follows in these footsteps. We believe our soon-to-be graduates made a great choice by becoming a member of the Walsh community. So now I'd like to start off and invite Dr. Tony Doney to lead us in the Pledge of Allegiance, and followed by Josh Neer, who will say our welcoming prayer.
Please stand. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
You can be seated if you'd like. So if everybody could just bow their heads for me and close your eyes. Dear Heavenly Father, I just want to thank you for this space. Thank you for Walsh University and just everybody here, every individual, Lord. We thank you for this program and the depth that it's helped us grow as future clinicians, as physical therapists. We want to thank you, Lord, for every faculty and staff member that's just been a part of our journey here and helped us along this journey, Lord. We just pray for your blessing over this class, Lord, that you continue to help shape and form us, Lord, into clinicians that would do your will out in the world. I pray that we're able to be shining lights in a world that can seem so dark at times, Lord. And I pray that you can help grant us your wisdom, your peace, and your strength as we provide care to patients, Lord. And I just pray for your unselfish heart, Lord, to be ours as we care for our patients and look more into their needs than ours, Father. In Jesus' name we pray. Amen.
So thank you very much. So to introduce myself, I'm Dr. Christine McCallum, and I have the pleasure of serving our program as the program director. It's been a great 2.5 years with these 32 graduates, soon-to-be graduates of ours, and we have a lot of nice things that we're going to be saying about many of you later on today. So I would like to do some introductions before we get into some of the more the fun stuff. So it is a great pleasure that I recognize our administration and our faculty and staff today. So please bear with me as I introduce them, and we'll go from there. So first of all, I'm going to introduce the president of the university, Dr. Tim Collins, and his wife, Drenda. Thank you very much for joining us, and I'm going to invite Dr. Collins up to say a few words.
Swords up! Swords up! Say hello here, everybody. Swords up. Say hello to me. Swords up. Swords up. Swords up. Everybody, swords up. So I'm not sure what to think. She says, okay, first we're going to introduce the administration and then we'll have fun. Okay, I don't know. I'm going to take issue with that, but we'll talk about that later. Okay, so one administrative note before I get started. So at 5:30, the nurses are having their cleaning ceremony over in the cleaning center in the gym. So if Dr. Dunphy and I slide out at 5:25, we mean no disrespect to anybody in this room. We're just going to slide out so we can make the next commitment. But I think we're going to be done by then anyway, so I should be able to stay here, ma'am, all the way through. So, dreams don't work. They don't. Dreams don't work. You know, as I was thinking about you all today, we had a meeting up in the GLC, and I was watching as you were moving over to set up for the symposium and carrying your gowns and moving around. And it sort of brought me back to that very first day of PT school. And Christine had invited me to come over and talk to you all. And I can remember coming across the academic quad thinking to myself, you know, it is a huge risk that people take when they try to pursue education at the level you just did. And if that wasn't risky enough, we're going to do this in the beginning stages of a global pandemic. These students have guts. And I think the reality is that it is not possible to live life to its fullest without taking risk. If you think about it, risk is actually woven in to almost every aspect of our everyday life. And so I think the greatest hazard that you graduates face in this moment of transition and as you move into actually using the knowledge and the skills that you've gained is if you decide you're going to risk nothing. I'm out. And I think if you do that, you're going to get at the end and you're going to have nothing. You're going to feel nothing. You'll have gained nothing. In essence, you'll become nothing. And you think about what it took to get you here in the first place. You had to take risk, but it was calculated risk. It's quite possible you signed up for a program, you went through a whole interview process, you were selected competitively, and you get here and you flunk out. You get here and you say, this isn't for me. You get here halfway through and say, suddenly life got in the way, and you're done. But all of those risks that you took, they were calculated, they were thoughtful. Because the fact of the matter is, you cannot grow unless you're willing to take a risk. And each one of you graduates that we look at today, that we celebrate today, are proof positive that if you take a risk, you're going to grow. Is there any graduate that feels right now, in this moment, you're in the same place you were 3 years ago? No, it's not possible. And that is why there's this enormous sense of pride that we all feel for you. Your university is proud, your faculty are proud, your families, your support structure, they're proud. Drenda and me, we're proud. We're proud of what you did. We're proud that you were willing to take the risk to, as Christine just said, allow yourself to be built into someone who will serve others in a way that very few others have a skill set like you now have. So as you turn this page and you go forth from here, I would hope that you spend some time and reflect on what I think should be the greatest lesson, the overarching, the omnibus, the uber lesson of this entire experience that you just went through. Dreams don't work unless you do. Swords up, swords up.
Well, that's going to be kind of tough to beat.
Well, let's just have fun.
All right, next I'd like to introduce Dr. Mike Dunphy. Dr. Dunphy serves as the Provost and the Vice President of Academic Affairs, so thank you very much for joining us. Dr. Pam Ritzline, who serves as our Dean of the School of Behavioral and Health Sciences, she is not able to join us this evening, but she does send her regards and her blessing, and she's so very proud of you. Dr. Ritzline is also a physical therapist. You had her in a class or two earlier in your curriculum, and you are in her thoughts and her prayers. So I want to say that from my perspective, and I'm aware of many different physical therapy programs across this country, we have the best administration, because without them, this program would not be in the excellent category. Thank you for your support, and it really, really means a lot. So thank you for being here. So now I'd like to recognize our wonderful faculty, your wonderful faculty, who have mentored these aspiring physical therapists in their journey. So I'm going to, as I say your name, you can stand up, and I just have a little blurb for you. So first of all, Dr. Lexi Larison. All right. Dr. Larison serves as our awesome, fearless Director of Clinical Education. She is the one that has navigated the pathways, the clinical education pathways for our students. And I just want you to know the depth and thought that Dr. Larison puts into guiding you into your clinical education experience is something to be recognized. So thank you. Next is Dr. Tony Doty, and as Dr. Tony Doty is our pediatric clinical specialist, and her colorful shirt says it all. So Dr. Doty brings color and play to our classrooms. She guides our students into understanding the world of development, and she is passionate about it. So thank you very much for everything that you do. Dr. Katie Fitzgerald is next. So Dr. Fitzgerald is one of our newest faculty members, but someone who has made an immediate impact in complementing our faculty. So if you haven't noticed, Dr. Fitzgerald was kind of the techie person behind the scenes or in front of the scenes helping out with our evidence-based practice presentations. And Dr. Fitzgerald is now our evidence-based practice coordinator, and I really appreciate your assistance today. So thank you very much. Next is Dr. Jamie Paz. Dr. Paz is a seasoned faculty member here at Walsh, and he brings a wealth of knowledge and calmness to all of us, especially to me. His insightfulness is sought out by many in many parts of our curriculum, and especially in the development of clinical reasoning, and I think all of you can attest to that with your algorithm projects. So thank you, Dr. Paz. Dr. Ryan Monty. Dr. Ryan Monty is probably best known in this class for his leadership in our community clinic. Dr. Monty is someone who I like to refer to as the encyclopedia of the MSK knowledge, because he is able to spout off a lot of things, and so I'm sure you guys can all recognize that. The depth of Dr. Monty's knowledge of current evidence and his ability to mentor students throughout our MSK series is noteworthy, so thank you. Dr. Lauren Roscoff is next. Dr. Roscoff is our course coordinator for our neurological course series. Her excitement for teaching our students about how to care for some of our most vulnerable patients and our clients out in the community is noteworthy. Her presence made an immediate impact in our curriculum, and you are all the benefit of that. So thank you very much. Dr. Alicia Walter. Dr. Walter is our cardiovascular and pulmonary specialist who brings a heart of gold, no pun intended, to her coursework. Dr. Walter is always looking to collaborate and to make connections and to help any way that she can, both within the program with students. So thank you very much for your service. Dr. Jenna York. Dr. York is the newest faculty member to our program, but she has also made an immediate impact in our foundational coursework. Dr. York has a quiet strength about her, which is very significant because she does a lot of things behind the scenes, especially helping out Ms. Pat Crum earlier today. So thank you very much and welcome to our faculty. We also have associated faculty members here with us. Dr. Dan Delarando. Dan mentored a research group. For those of you who may not know, Dan is a 2019 graduate of our program. He is now a clinician at The Ohio State University. And when Dan was a student in our program, he actually won our research award way back when. So we're glad for you. Thank you, Dan, for your service. We also have Dr. Amy Hassan Miller, who is here, and we'll talk to her about a little bit more about her later. But Amy, one time I said retired, but she stepped away from full-time academic faculty last spring, and she stayed on and she mentored her research group and did a fabulous job, and your group did a fabulous job. So we are glad that you are here with us today. We also have Ryan Monty here with us, or Ryan Vitzel. Gosh, Ryan, I call him Ryan squared. Yeah, Ryan Vitzel is also a grad of our program, but he has been one of the biggest supporters, and he comes and helps out in lab. Anything that we ask Ryan to do, he's all in, so we do appreciate that. And so I saved the best introduction for last in my mind. It is Miss Pat Crum. So we should probably give her a standing ovation. So Pat is really the glue that holds this program together. I say that all the time. She's made today possible, keeping the faculty sane over the last the month, finishing up 2 classes, getting ready for your graduation and today's event. So thank you very much for working with us. So each of these individuals has spent countless hours preparing all of these courses that our doctoral students took. They handled that first year of your program, I think, with professionals, with grace. We were in COVID times, and we had to do some pivoting, and we had to learn different teaching models. And you guys were graceful and worked with us and tolerated us and provided us feedback, and for that we are forever grateful. But I want to thank all of them for their service. So one more. Okay, so I still have a few more introductions, but hopefully this is the fun stuff, because now it's all about you guys. So I would like to introduce the student leadership team for the class of 2023. There were 5 individuals who were elected as class leaders back in November of their very first semester with us. We always hold it on election day. These 5 individuals probably had no idea what they were getting themselves into, but they put their names out there and served their class and worked with the faculty. So the class president, David Taylor. So thank you very much, David, for your service. Treasurer, Ethan Donner. Treasurer, Ethan Donner. There you go, Santa, there he goes. The fundraiser, Chloe Bertkey. Did I pronounce that? Class liaison, Maria Wells. And our East Central District liaison, who is the liaison to our professional association, Colin Cottrell. So thank you very much. So the one thing I want to say about this leadership team is a few years ago we started trying to integrate the classes instead of having silos. And these 5 individuals under David's leadership excelled at that. They brought together we now have a cohesive team of first year, second year, third year leaders. It's an evolving process, but because of their willingness to work with the faculty under Dr. Walter and Dr. Larson as their faculty mentors, they did some really great stuff. There was a lot of service hours that were provided by this class. Early on, there was a Bible study among students that was started, and a lot of the things that were behind the scenes that I know that will be continued on within the program, all because of their leadership, and also all for the rest of the classmates working with them and believing in them. So thank you very much all for your service. All right, now here's the really fun part, because the class of 2023 selected Dr. Amy Hassan-Miller as your class speaker. So Amy is a lot of fun when she gets going. So Dr. Hassan-Miller was instrumental in you all being here, because at the time when she was on our core faculty, she was our admissions coordinator. And so she led that process of reviewing all the applications, selecting our interviews, if you guys can all remember that, and led that process. So we are glad that you are all here, and we were glad that Dr. Hassan-Miller was there at the time and helped us through that process. As I said a few minutes ago, that Dr. Hassan-Miller stepped away from academic teaching last summer, and she's on and doing some great things with her family and within the community and making a difference, just not in full-time academics. But I was over there asking her if she'd like to come back and help us out in some classes every now and then. She smiled. Yeah. So we are pleased to have Dr. Amy Hassan-Miller and as your keynote speaker. And I'm looking for the microphone. Oh, it's over. You're okay? Okay. All right. She wanted to move at first. But there we go.
Thank you, Dr. McCallum. Wow, it is good to be back, let me tell you. So, let's brainstorm some possible causes of anterior shoulder pain. No, graduates, loved ones, distinguished faculty, staff, guests, I am so honored and so pleased to be here with you today. And class of 2023, thank you for inviting me. As you all know, you hold a special place in my heart. You are the most thoughtful, kind, loving, supportive cohort I have ever worked with. Don't tell the others, but it's totally true. So, 6 weeks ago, my husband and I, along with our 4 children, took the trip of a lifetime. We cruised the Mediterranean and we stopped at places like Egypt, Jerusalem, Bethlehem, Cyprus, the Greek island of Rhodes, and Ephesus in Turkey. Trip of a lifetime. And I was so excited to see the pyramids. So we board our ship, we spend a full day at sea where we played a boatload of cards. See what I did there? And then we had arrived. Now, Egypt doesn't love us right now. And so our tour bus entourage was honored with a police escort. So we drove and drove and drove along with these guys with these big guns. But finally, we arrived at one of the wonders of the world. We hop off the bus, we get on a camel, we ride for 10 minutes, then we get off the camel, we walk over to another pyramid, we go inside, look at a tomb, come outside, get back on the bus. Seriously. We had flown across the world, spent a full day at sea, 3 hours on the tour bus to spend an hour, maybe less, at the pyramids. It was such a whirlwind that I didn't even have a chance to appreciate it. Can you relate? Anything in your life feel like this? Maybe the last 6 to 7 years? Well, this is your moment of enjoyment, and I'm going to make sure that you take it. You have made it to the finish line. You have ran your race with endurance and success, and now is the time to bask in the glory. Reflect back on that transition from high school to college. You might have left home for the first time, or maybe you balanced home life with family life. New friends, new experiences, new responsibilities, maybe laundry, new stresses, new opportunities, new successes. And then you got to apply to PT school. PT CAS. Need I say anything else? Where should I apply? How many schools should I apply to? What should I write in the essay? Do they even read it? What should I wear to the interview? What if I don't get in? What if one school accepts me, but I don't hear back from the school that I really want to attend? What even is the school that I really want to attend? And then there was a transition from undergrad to graduate. And many of you may not have even anticipated the struggle with this one. But all of a sudden, you have the same class with the same 32 people all the time. You have to strip down to your sports bra in class. Wait, you can't wait till the night before to study and get an A? They don't give you a study guide? Where is the extra credit? And maybe, for the first time in your academic career, you might have failed at something, and there might have been tears, and they may have been in my office. And so now that you're graduating, what are the skills that you need now? Networking, manual therapy, big and loud, dry needling? I'm going to suggest to you today that it's to pause, slow down, and enjoy the moment. Wait, I have to practice that? Yes, because you have been on the fast track to checking all the things and doing all the things, and it has been a whirlwind. And now that you're graduating, it's done, right? Life's gonna slow down, right? No. I would venture a guess that the next 5 to 7 years of your life, you will see the most change than any 5 to 7 year period of your entire life. Think about what might be next for you. Maybe a move, new job, new friends, maybe a wedding, maybe a child, more children. And what about your PT professional development? What continuing education are you going to take? Are you going to pursue a residency, a fellowship, a specialization? What leadership opportunities are you going to go after? How will you serve your community? How will you serve your profession? If you're not careful, you will always be thinking about the next thing. I should get this certification, that car, we should have a baby. Let's put an addition on the house. You will always be striving for something because you are achievers. I think Dr. McCallum first approached me about speaking today back in January, and I immediately knew that this is what I wanted to say to you. Pause, slow down, and enjoy the moments. Ironically, last weekend I spoke at a conference, and the theme was Psalm 23. The Lord is my shepherd, I shall not want. It's really good, right? But it's this next part that reaches out, grabs a hold of my heart, and gets my attention. He makes me lie down in green pastures. He leads me beside still waters. He's telling us to pause, slow down, and enjoy the moments. American actress Jessica Lange said, ultimately, your life is made up of moments. So don't miss them by being lost in the past or anticipating the future. And I agree. We've got the Bible, and we have an actress now telling us to pause, slow down, and enjoy the moments. I'm goal-oriented, you're goal-oriented. I love that about you. I love that about me. But there have been moments in my life where I am so fixed on the to-dos and the next goal that I have completely missed the now. I don't want that to happen to you. So listen to Psalm 23:2. He makes me, it literally says makes me, lie down in green pastures. He leads me beside still waters. How peaceful is that? Right there in the Bible. Pause, slow down, enjoy the moments. Start right now. Stop thinking about how the boards went or what you said in the research presentation, what job you're going to get, where you're going to live. And look around. Look at these students who have become your family for the last 3 years. And look at your family who's always been your family. And then you have the families of your classmates. I mean, honestly, this is like the wedding reception of your DPT class. So, as you look around, what do you see? What do you hear? What do you smell? What do you feel? Seriously, how do you feel right now? Are you nervous, excited, scared, happy, hopeful, optimistic, grateful? These are the moments. And I want to challenge you to enjoy them because by definition, they are but a moment. They do not last. And I don't want you to miss out on them because you are so fixed on what's next. In fact, I challenge you today to make these moments in time eternal because you are so present and you are appreciating every detail of them. So, at the conclusion of my trip of a lifetime, which really was amazing, we docked the ship in Athens, Greece. We hired a driver to take us the 20 minutes to the hotel. He's got a sign just like the movies. So we hop in the car. After an hour and a half, he's like, hey, I can't get you any closer to your hotel than like a mile and a half away because the streets are closed. It's Greek Independence Day. I had no idea. So I'm thinking, no big deal, we love to walk, and how cool is it that we are in Greece on Greek Independence Day? So we take off trekking through the city. Did I say trekking? Because I really mean sprinting with our luggage in tow because my husband had an agenda. So picture of us, 6, sprinting through the city. And after about 7 wrong turns, we find our hotel. We drop off our luggage and we start the uphill journey to the Acropolis. Closed. Greek Independence Day. Fill in the blank for anything that we had planned to do in Athens. Closed. Greek Independence Day. So, although I've never done this before, we drop our kids off at the hotel and we find a nearby cafe. And my husband and I paused. And we both look back at this as one of our fondest vacation memories because we slowed down and we just enjoyed being with each other. And so this is my wish for you, that you pause, you slow down, and you appreciate who you are with right now and enjoy the moment and repeat daily. Thank you.
Thank you, Amy, for those words of advice. I'm going to take them up on it. Stop and pause and enjoy the moment. So, thank you. All right, next on the list is I would like to invite Maria Wells up to the stage. Maria was selected by her classmates as the class speaker for the DPT class of 2023. The class shared that Maria is one of the most kind-hearted and thoughtful individuals that they have ever crossed paths with. She is positive, genuine, and always keeps a level head. Maria has talents that transcends many areas, in addition to her skills and talents that she achieved over the last couple of years as her study as a physical therapist. She has been a leader for this class and has made a positive impact on all of her classmates. The class of 2023 could have not found a better person to represent them as your class speaker. So welcome, Maria.
Thank you very much, Dr. McCallum, for the introduction. That really means a lot. First of all, I'd like to congratulate my colleagues on successfully presenting your research projects. It's been a long journey, and I'm sure it feels good to have that behind you. And also for fulfilling all the requirements for graduation. It's definitely been a long, challenging 3 years, and we should all be proud of the hard work that we have put into this degree. I would also like to thank all the faculty, the friends, and family members that attended today. I know I don't speak for myself in saying that it means so incredibly much to have people here that provided an immeasurable amount of support these past 3 years to get us to where we are at today. I'll be completely honest in saying that when I first began to prepare for this speech, unlike Dr. Hassemiller, I had no idea what I wanted to say. After all the reflection papers that I've completed these past 3 years, I thought, hey, how hard could this be? But as I quickly figured out, it was going to be a challenge. Summarizing the past 3 years is a difficult task, and I'll do my best to not only do that, but to also provide some advice we'd be wise to keep in mind as we begin our careers. As I was preparing, I kept thinking back to all of the interactions that I've had with my patients during my clinical rotations. Some extremely positive, seeing some very exciting things, and some, a little bit more difficult and challenging to work through. We work in a profession where we have a unique opportunity to spend a lot of time on our patients compared to other healthcare professionals. This allows us to get to know our patients on what I believe to be a much deeper level, and they also get to know us. Throughout a patient's plan of care, we often see them at their lowest points and carry their burdens right alongside with them. This can be difficult and sometimes a little exhausting at the end of the day. Sometimes it feels like there's just so many factors that are out of our control. However, with this in mind, I want to leave you all with some encouragement to help us understand the profound impact that we have on our patients' lives despite the challenges that we may face. One of the things that I greatly value about Walsh's DPT program and the university as a whole, as Dr. McCallum and Dr. Collins already alluded to, is creating a service attitude in their students. I believe that this is one of the many things that adds to the uniqueness of our program and is the reason why Walsh DPT graduates become so successful in their careers. Service seems simple enough, but why is it important? What does it truly mean? I believe it's crucial to define because I would argue it's the crux of our profession and the very principle in which it was founded upon. One individual that embodies what it means to have a service attitude is a woman by the name of Mary McMillan. Some of you might recognize the name, but for those of you who do not, Mary is recognized as being a large reason why the physical therapy profession was started in the first place. Born in Boston, Massachusetts in 1880, Mary experienced significant loss at a very young age. Her sister passed from tuberculosis, and her mother passed away from complications in childbirth. Her father sent Mary to live with her aunt in England, where she learned to use her sufferings as motivation to help others. Her aunt raised her to be strong and resilient, two skills that would be crucial for Mary in the future. She had a passion for anatomy, physiology, and rehab, and was convicted that herself and that every person on this planet has a specific vocation in which they are called to pursue. She wrote in a diary entry that she always followed her heart, which was at times difficult, especially as a woman during that time. However, she believed that her gifts could help many patients, even though that following her heart sometimes involved making some sacrifices. After completing her education in England, she saw that there was a need for rehab services in the United States and found herself at the Children's Hospital in Boston, helping to treat kids diagnosed with polio. Soon after she came to the States, World War I broke out, and she followed her next calling. She was sworn in as the first PT into the U.S. Army Medical Corps. Her official title was a reconstruction aide, since the term physical therapist didn't exist yet at this time. She worked at the Walter Reed General Hospital in Washington, D.C., helping the young men who were injured in war. Mary continued to serve not only her patients, but became a mentor to over 200 other students who were learning to become reconstruction aides. In 1921, she founded what was known at the time to be the American Women's PT Association as a way to standardize PT practice and also bring clinicians together. Later, it was renamed the APTA. In her diaries, she writes that she was worried that her attempts to create an organization would flop. Well, here we are, over 100 years, and our profession continues to grow. However, it was not until she founded the APTA that she faced perhaps one of her greatest challenges. She followed another call to move to Beijing to establish the first physical therapy school. She was not there very long before war tensions began to grow, and again, she could sense that another world war was on the horizon. She began to fear for her safety. Unfortunately, she was unable to move back in time, became a prisoner of war, and was sent to a prisoner camp in the Philippines. Here, as you can imagine, prisoners faced abuse, placed in close-quartered spaces, and diseases were rampant. However, Mary was a firm believer in using her God-given talents to help others no matter where she was at. She took it upon herself to set up her own PT clinic in the camp and provided rehab to those in need. The following quote that I'm going to share is from one of her diary entries. While it was one of the most difficult and challenging times in my life, the one outstanding joy during that time was the enjoyment of helping others and providing service for no money and without price or equipment, performing without adequate food to keep our bodies' fires burning and with little comfort, clothes, or hope. What a legacy that Mary left for all of us. Despite the numerous challenging situations that she faced during her lifetime, she consistently put the needs of others before her own. And so because of this selfless service heart, there are several points that I think we would be wise to take away from her story. First, pursue what you are passionate about and determine your individual talents. This is going to look very different for every single one of us, but pursuing areas which we are passionate about allows us to be open to new experiences and greater opportunities to help us grow, even though it might not always be easy. Our gifts and talents are meant to be shared with others, because otherwise, what's the point of having them? Mary is a great example of what it means to be a service leader. She recognized the needs of others by moving across the world to share her knowledge with other clinicians. She did not lead for recognition or fame, but with a genuine passion to instead serve others and lead by example. Honor, inspire, and empower others, and not for your own profit or glory. Another lesson that those who create the greatest impact are often the most humble. As Mary wrote, she had her doubts about herself and her goals. However, she still believed that she could make a difference in the lives of others. I found an article published in the BMC Medical Education Journal that interviewed physicians who were nominated by their peers as being excellent clinicians. Researchers wanted to determine which attributes made a great clinician, and one of the most striking insights into this article was that all of the clinicians agreed that humility was a crucial piece of wisdom needed in order to excel, make the most impact in the lives of our patients, and work effectively with their peers. The clinicians in the study note that in order to be humble, it is important to realize what we don't know. This should lead to a desire to learn and grow from our mistakes, but should also spark curiosity as well. Rather than becoming self-conscious about our lack of knowledge and viewing this in a negative light, we should use this to spark our determination to find solutions to be able to provide better care. This also allows us to become lifelong learners, to constantly be seeking out answers to do what is best in the clinic. One of the clinicians states that it is a dangerous spot to be a healthcare worker and pridefully think that one has all the answers. Although this article specifically interviewed medical doctors, I believe that the same principle applies to us, especially since our practice is constantly evolving. We should never settle to do the bare minimum. Go above and beyond for your patients in order to maximize their potential. To close, I hope I have helped you begin to understand what service might look like in our careers. Our patients definitely know the difference between clinicians who have a servant attitude and those who do not. Recognizing this principle, I think Aristotle stated it best: the essence of life is to serve others and do good. I want to end with an analogy that a patient's spouse shared with me during one of my first clinical rotations, and it's something that I've just never forgotten. This analogy comes from the great biblical patriarch Moses, who I'm sure many of you are familiar with. There's a story in the book of Exodus where Moses had his arms stretched out over his head, offering prayers to the Lord while his army was in battle. He did this so that they could win. However, he grew fatigued and his arms began to drop towards his side. So 2 of his followers came back alongside of him and helped him hold his arms up overhead so he could continue to pray for his army. Because of this great act, they ended up winning the battle. The patient's spouse went on to say that this is how she views healthcare workers, as being the ones to help lift a patient's arm up over their head to help them press on and fight whatever battle they might be going through. I know that my classmates can think back to numerous patients that were struggling to overcome various battles. Perhaps it was helping a patient with chronic pain who has plagued them for years. a patient who maybe just received a degenerative diagnosis, a star athlete who's sustained an injury that threatened their ability to continue to play for scholarships in college, a mother who's learning how to care for a child with a developmental disability, and the list goes on. I share this story so that you may never underestimate the impact that you will have in the small encounters with your patients. They will never forget the moments when you went above and beyond to provide individualized, compassionate care and to make a positive impact on their prognosis and quality of life. They will never forget that you came right alongside them to help support them in their battles. Classmates, colleagues, and friends, remember to have a service attitude, as this is the foundation for our profession. Pursue what you are passionate about, lead by example, and embody the virtue of humility. I'm going to go off script a little bit and just say it's been such a pleasure getting to know each and every one of you. I'm truly honored to be a part of this cohort, and I'm just so excited to see what everybody's going to do with their careers. So with that, I wish you all the best, and congratulations on graduation. Thank you.
That was beautiful, Maria. Thank you very much. So now we enter the awards part of our celebration. While each student in the class of 2022 has made tremendous efforts in your educational endeavors over these past 2.5 years, the program recognizes some student achievements with some awards. So if your name is called with one of these awards, we ask that you please come forward. You will receive a pin or a medal, and then we ask you that you can wear those on graduation day. And then if anybody in the audience wants to take a photo or whatnot, you're also welcome to come up and do so. We'll pause for that as well. So I have the honor of awarding students in the National Physical Therapy Student Honor Society. Oh, let me say, Ms. Crum is going to come up and help with us. I apologize for that. So, see, I tell you, she has our back. So, come on up to help with this. So the National Physical Therapy Student Honor Society is sponsored by the American Council of Physical Therapy, or ACAP. This society honors students who demonstrate excellence, integrity, and professionalism in the areas of student achievement, leadership, and service or research. Students must be in the top 25% of their class academically and be members of the Physical Therapy Association. So this year we are awarding Honor Society to 2 students. So I'm going to call Elena Duffy up first. Just hold on to that. So Elena served the community in the program over the past few years. Sorry, come stand next to me. She served as a buddy for a child with autism during a sports summer camp, volunteered as a course guide in Girls on the Run 5K held in Canton during the pandemic. I remember that one. Everyone was so excited to be outside again. And she also served as a tour guide for the program during open houses for potential students and families. Elena's leadership abilities emerged over the past few years, and you did a wonderful job on your evidence-based practice project. So speaking out in public, I'm sure that shows leadership skills right there. And she served the lead author for that group. She was also a team leader for our community clinic for the scheduling team, and without your efforts, it would not have been the success as it was. So we are welcoming Dr. Elena Duffy to the National Physical Therapy Honor Society. Next, I will call up Maria Wells. So Maria served the community and the program in numerous capacities during her time with us. She has been a regular volunteer at Pegasus Farms, and I'm sure that has been tremendous fun. And assisted with our interview process for our new faculty members. And she also reviewed abstracts for the Ohio Physical Therapy Association and for their state presentations. We don't see a lot of students doing that, so thank you very much for that service. Maria's service was also combined with a leadership opportunity as she served her class on the Student Leadership Board as a class liaison. And I do have to recognize Maria in that role because I hardly ever heard from her. So from my standpoint is that she did her job tremendously well, working with her classmates as teammates and with the faculty and resolving things where they needed to be resolved versus bringing them up to my office. So with that, I thank you very much. So Dr. Maria Wells.
My name is Dr. Alexia Larson, and I am honored to be presenting the Joan C. Nethery Clinical Excellence Award. The Joan C. Nethery Clinical Excellence Award was established in 2000 with the graduation of Walsh University's first PT class. The intent of this award is to honor a student who actively accepts the diverse role of a physical therapist professional, including the ability to work with a variety of patient populations and professional staff, and who is an advocate not only for the patient but also for our profession. This individual exhibits the potential to demonstrate clinical excellence after graduation and become a clinical mentor to fellow colleagues and students post-graduation. The criteria for selection is as follows. The awardee must be a member of good standing of the American Physical Therapy Association, must have good academic standing, must have positive ratings in all 4 professional experiences, must have experienced physical therapy practice in a minimum of 2 different practice settings that encompass the lifespan of patients, must demonstrate professional behaviors consistent with the core values of the physical therapy profession, must have demonstrated exceptional service to one or more of the following: the PT program, the university, the professional association, or the community. The Director of Clinical Education will nominate potential awardees, and the award is selected by the faculty. The 2023 Clinical Excellence Award goes to an individual that positively shines when it comes to embracing clinical education and all of the associated opportunities. She has completed professional clinical education experiences in outpatient and acute care settings and sought out a highly specialized oncology hospital for her final rotation. Clinical instructors and faculty have taken notice of her bubbly personality, her positive attitude, and her desire to serve others with compassionate care. This student was instrumental in ensuring clinical excellence during the 2023 Walsh University Doctor of Physical Therapy Community Clinic by serving as one of the project managers. The class of 2023's Clinical Excellence Award goes to Jordan Langkamp.
Hello, I'm Dr. Alicia Walter, and I'm honored to present the Professional Service Award for your class. The Professional Service Award was established in 2005. This award was initiated to acknowledge a student who demonstrated exceptional contributions to the physical therapy profession during their tenure as a student in Walsh University's physical therapy program. The criteria for the selection are as follows. The awardee must be a member of good standing of the American Physical Therapy Association, must have good academic standing, must demonstrate professional behaviors consistent with the core values of the physical therapy profession, must demonstrate involvement in the profession in the promotion of physical therapy or community service that enhances the health, promotion, or wellness, must demonstrate contributions to the professional organization, must have held leadership positions may have held leadership positions at a district, state, or national level. They would be actively involved in the Ohio Student Special Interest Group or attended state and national conferences and reporting back to fellow students. So those are all the possible things that a service awardee could encompass. Faculties nominate the potential awardees, and then the award is selected by the faculty. Hebrews 13:16 states, "And do not forget to do good and share with others, for with such sacrifices God is pleased." The recipient of this award has graciously shared her time and talents in the service to others. She has shown a great commitment to service over the course of the Doctor of Physical Therapy program in a variety of areas. She's provided over 200 hours of service to the community in an area that she is passionate about, which enhances the lives of others. She has also served our physical therapy program throughout our admissions interview process and interview process with faculty. Her professional organization, she's also served as a reviewer for content at state conferences. She served her class as the liaison between peers and faculty and serves as both an advocate in service to her patients, which I'd like to share what one of her CIs had to say about her. She is single-handedly the best student I've encountered throughout my 3 years at Baptist Health. In the continuously evolving status of a patient, she is a constant resource and advocate for her patients. She provides a sense of calm, superior level of knowledge, high adaptability, proficiency in mastering new skills and treatment techniques which allow her to provide the best level of care for her patients. She not only excels in understanding the disease process and implementing interventions to address each impairment, she truly understands the social component and the impact that sincere compassion and support have on her patients. When patients struggle with a loss of independence and life-altering impairment, her communication and interaction with her patients and family members is arguably what sets her apart from others. I would not only trust but request for any of my closest family and friends to be treated by her. It's with great pleasure that I present the Professional Service Award to Maria Wells. Thank you for your service.
Hi everyone, I'm David. I am the class president for the DBT class of 2023, and it is my honor to give the Peer Recognition Award today to one of our classmates. I don't know when this award was established, so I don't have any specific details for you other than the criteria for selecting this award was that our class voted on who was most deserving for this award, and I can't think of a better person to give this award to. This individual spent, I imagine, numerous hours gathering all of us together as a family, and I can say with complete confidence that she was an instrumental piece in creating opportunities for us to all gather, not only together in class, but outside of class as well, through various activities, food, games, you name it. She probably had a hand in it. And I think there's no better way to give an example as for why this person is so deserving, as from the very beginning of school, she actually put almost all of us, if not all of us, into a Facebook group, like in, I don't know, June, something very early before we even started. So it's my great pleasure to announce the Peer Recognition Award to Kayla Richard.
Okay, so I am very honored to present the Research Excellence Award. This award is given to a student or student group who has demonstrated exceptional productivity during the research processes within the evidence-based coursework. Eligibility for this award requires demonstration of mastery of the material within the research processes of the curriculum, completion of a project of distinction within the research series, demonstration of potential future scholarship in discovery. Faculty advisors may nominate potential awardees, and then the award is selected and voted on by the faculty. A comment about this group. This group didn't really know what they were getting into at the beginning of the project. I think that goes for everybody sitting out there that completed one of these projects. But this occurred as the faculty's original research idea was hampered by challenges associated with the data. Therefore, they quickly pivoted into a quality improvement project to evaluate the systems and processes for our program's annual community clinic. The knowledge they gained from this project and the recommendations they made helped guide the successful implementation of the class of 2023's community clinic. They were an outstanding group of students with whom to work, as they were independently driven and very results-oriented. So the 2023 Research Excellence Award goes to Lauren Ricosi, Joshua Neer, Rosie Freeby, Caleb Freeman, and Rachel Thorne for their project entitled Walsh University's Annual Checkup by a Physical Therapist, Outcomes from a Quality Improvement Project.
the last award here, the Academic Excellence Award. The Academic Excellence Award is bestowed to the student who has demonstrated consistent academic achievement throughout their curriculum, as evidenced by a superior grade point average and professional behaviors. This student also exemplifies the characteristics of a lifelong learner and is a consistent contributor to positive scholastic experiences. Criteria for the award includes excellence in grade point average, demonstration of leadership, recognized potential for continued academic excellence, and outstanding professional behaviors. This award is nominated and selected by the faculty, and we talk a lot about different things, and we spend a lot of time thinking about this. So this was a hard one, but we picked the recipient of this year's academic excellence that goes to an individual that, from a personal experience, has always been engaged in class, contributes to a highly constructive learning environment, is very easygoing, but knows what is going on. And in addition to maintaining an excellent GPA, this award recipient has also served in 3 successful leadership roles, including Gigi's Playhouse, and never hesitates to lend a helping hand. She is enthusiastic, insightful, and strikes a good balance between looking out for the details, but is able to see the big picture in a calm and clear manner. I'm honored to announce that Lauren Ricosi is the recipient of the Academic Excellence Award.
Hi everyone, I'm Dr. Ryan Monty, and this evening we will induct our graduates into the physical therapy community through a series of ceremonial events. Graduates will receive a prayer of blessing over their hands, receive a symbolic pin, have the option to receive an individual blessing of their hands with holy water, and finally recite the oath of a physical therapist with faculty and all physical therapists who are present. Graduates, I now welcome Ben Walther for a blessing of hands prayer.
Good evening, graduates, and congratulations to you and all of your many accomplishments. I'm not a priest. Normally a priest confers this blessing. So I think what I'd like to do is ask all of our graduates to stand. And what do you do when you receive a gift? You put your hands out in front of you as a sign of openness to receiving such a gift. So what I'd like to do is lead us in a prayer and just invoke the Lord's blessing upon you. That God would use your hands and your whole being to bless the lives of others. So please pray with me. As we pray, if you wish, you can put your hands out like this, just as a sign of receiving a blessing if you wish. In the name of the Father, and the Son, and the Holy Spirit, amen. Lord Jesus Christ, look upon these hands, which your servants wish to set apart for your service beginning today. May these hands always give a touch which heals. May these hands comfort the distressed and restore quality of life to those who are weak. May these hands give dignity to those who are vulnerable and joy to the elderly. Lord, may these hands always love and never settle for mere duty. May these hands work with compassion and mercy rather than mere politeness and professionalism. And finally, Lord Jesus, we ask you to stretch out your own hands to bless these young people as they begin this new chapter in their lives, that they would always value the things of the Spirit and seek the healing and grace which only you can give. May they always feel your merciful touch, calling them to a deeper relationship with you, who alone can give the peace which the world cannot give. And finally, may the Lord bless and prosper your work, graduates, and your ministry, and bless the world through you. We ask all of this through Christ our Lord. Amen. And you may be seated.
Okay, I'm just directing traffic here for a minute. So what we're going to do, graduates, during this part is I'm going to call you up by name, and we're going to proceed in a counterclockwise fashion. You will receive a pin from Dr. Larson, and then Dr. Dunphy and Dr. Collins will greet you and congratulate you. Those who wish to have a separate blessing can then stand by Ben, and he will offer that to you. If you wish not to, then simply proceed back to your seat, okay? And I have to say, you know, I got to make sure my eyes aren't fogging up. I'm on the verge here of like goosebumps and some you know, waterworks, so bear with me here. All right, you guys ready? You get to move around too, which is great. All right, so first up, Chloe Bertkey. Yeah, well, I guess we'll do an applause at the end, right? You want to do that? Okay. Colin Cottrell. Ethan Donor. Elena Duffy. Caitlin Zuroff. Kelsey Fiorello. Rosemary Freeby. Caleb Freeman. Caleb Graveldinger. Emma Kondiker. Nathan Langenfeld. Jordan Langkamp. Cade Lloyd. Kara Marshall. Alan Miller.
Not crying about you, AJ. It's okay.
Brooke Miller. Tyler Missler. Beth Myers. Joshua Neer. Sarah Overberg. Zoe Puller. Kayla Richard. Lauren Skillman. Lauren Ricosi. I went out of order, sorry. my hand moved. Okay. All right. Sean Sweeney. Catherine Tefelsky. David Taylor. Rachel Thorne. Megan Tondra. Corey Tomick. Maria Wells. And being pinned from afar is Connor Huluk. Hey, swords up! Let's go!
If you turn to the back of your program, you'll find a separate insert that contains the oath of a physical therapist. And it's at this time I'd like to invite the class of 2023 to come up and join me in the front here, to the side, where there's more room. Oh. It's in the back of the program. Yeah, it's fine. Yes. I guess fill in wherever you'd like. Graduates and physical therapists, please recite with me the oath of the physical therapist, which can be found on a separate letter. All physical therapists are welcome to renew their oath. In the presence of my colleagues, friends, family, and teachers, and in the view of the honored profession I'm entering into, I solemnly and willingly state that I dedicate myself to the following. I will practice physical therapy with compassion for the vulnerabilities in each of my patients and will work to preserve their dignity and promote their health and welfare. I will value the lives of my patients as I value my own life, through my concern for their significance and with respect for them and the confidential nature of our relationship. I will be humble. I recognize my limitations and will continue to consult with my colleagues and coworkers for knowledge with which I can better treat my patients and for the inspiration to expand and augment my education. I will share my knowledge with my colleagues and patients freely, with compassion and patience. I will work toward the improvement of the quality of life for all of my patients. I will honor the choices that my patients make with respect to their wishes and needs. I will do no harm to another human. I will work to improve the practice of physical therapy so that all who seek it will receive treatment which is proper, ethical, and just. I will not allow my judgment regarding the practice of my profession to be influenced by the race, creed, religion, greed, or unethical behavior. I will expect the same behavior from my colleagues and coworkers. Thus, with this oath, I freely accept the obligations and rewards which will accompany my practice of physical therapy.
That's beautiful oath, and something that all your faculty take seriously, and we know that you will too as you go throughout your careers. So, in closing, I want to thank each and every one of you, the 32 of you, for your dedication to your studies, and for your support as we navigated some changes over the last few years and your 8 semesters with us. And to trusting the process. It's not easy to trust a process and when you're not always sure where we're going. But you trusted us to guide you, and you got to the end. And as we leave you, you are not just our students, you are now our colleagues, right? I'm not your program director, I'm your colleague, and every single one of your faculty, we are colleagues in this great profession of physical therapy, and we welcome you to our profession. So, as I leave this stage, I have a prayer for you. It's one of my favorite blessings, and I might cry, so I apologize if I do. So, may the road rise up to meet you. May the wind always be at your back. May the sun shine warm upon your face. The rain falls soft upon the fields, and until we meet again, may God hold you in the palm of his hand. So God bless you. As you leave today, I know you have a slideshow that you want to share, but as you leave today, Ms. Crum has prepared something for you over on the table, so please make sure that you get that. After your slideshow, if you would like to have a class photo, we would like to have one. We can gather over at the screen with this in the background, and we will take a snapshot of that. And then we will see you on Saturday in your caps and gowns, and we will be so excited that you are really doctors of physical therapy. So congratulations, and God bless you.